old age or our own impending death. A key part of aging well philosophy is to do just that. It provides peace of mind and essential clarity in our lives and clears the way for the most important part, to live and celebrate each day to the very fullest. The focus of today's session is healthy aging. We will first talk about preventive care for healthy aging of the body. We have Dr. Anjali Sukham. She is an internist and a primary care physician. She works for Palo Alto Medical Foundation in Los Gatos. She will be talking about regular checkups, immunizations, diet. She will talk about risks of diabetes, heart attack, stroke, obesity, all issues that we as Indians are dealing with in Silicon Valley. Dr. Sukham's perspective is especially important as she is a primary care physician, the doctor we go to for regular checkups, and the first doctor we go to if we are ill. Our next speaker will talk about preventive care for healthy aging of the mind. Dr. Rita Ghatak, she's a gerontologist. She started the aging program at Stanford and is the founder director of Aging 101. She will talk about cognition, how to maintain a sharp memory, alertness, sense of engagement, and decreased risk of depression, dementia, and Alzheimer's. What steps we need to take if we notice mental decline in our family and friends, all extremely important issues in today's world. Our third speaker will talk about being prepared for serious illness. She will focus on conversations on advanced healthcare directives. You probably are all familiar with advanced healthcare directives. This is a document that makes your healthcare wishes known if you are unable to talk for yourself. So your doctor and family knows what kind of medical care is important to you. This is especially important for us, as studies have shown that a smaller percentage of Indians have filled out their advanced healthcare directives as compared to a general population, even in the Bay Area, even though we have a higher education and socioeconomic level. So it is our population that gets into trouble when a family member gets ill. She will talk about palliative care. You want to ask your doctor for this kind of care, and she will introduce hospice care also. Who are the most vulnerable people in our community? I'd like to share my thoughts with you here. I'm a pediatrician. I take care of babies and newborns. They are helpless and they are vulnerable, but they're also cute and cuddly. And everyone wants to be around them and take care of them. And then we have the old, the frail, and the sick, who are also helpless, but they are not cute and cuddly. But they are in great, great need of care. So I would say it is our old, our frail, and sick people in our community who are the most vulnerable and in need of most care. And I came to this realization when my mother fell terminally ill. And this is what got me involved in this cause and really understand the importance of it. The true measure of any society can be found in how it treats its most vulnerable members, Mahatma Gandhi. With that, we start today's session. I'd like to invite Dr. Anjali Sukham to talk about healthy aging of the body. We will have a Q&A session at the very end. We'll have our three speakers, so do hold your questions. You can write them down, and we'll have a good amount of time for Q&A session at the end. Thank you.
Thank you.
Thank you, Dr. Kapoor, and thank you all for inviting me. The way I understand it is I should try and give you information, but I also want to give you information that you can maybe pass on to people that you may be counseling. So you're already doing your civic duty and giving back to the community, and I applaud you for that. So as Dr. Kapoor said, I am an internist of internal medicine, and I see a lot of older people, so I will be talking about aging. Internal medicine is a specialty where we see people over the age of 80. So as I often say, children scare me, but give me a 105-year-old and I'm okay with that. I work for PAMF in Los Gatos. A lot of the information I'm giving you is from the USPSTF, United States Preventive Services Task Force. They are the entity that look at all the evidence that we have and give us information on what we should be telling our patients to do. The USPSTF is what tells us, what incentivizes us as physicians to do what we call evidence-based care, something that we have data on that we would like to then tell our patients. So, there are different age groups that there are different screening tests that are recommended. So people under the age of 50 should be going in, women should be going in for routine pap smear screenings. When I first started in practice, we would tell our ladies to come in for PAPs every year. Now that has changed because we can now check for HPV. HPV is human papillomavirus. That's the virus that leads to cervical cancer most of the time. And so the recommendations have now changed for 30 years and older, where we are doing PAPs every 5 years. So there are some changes that have happened maybe in the last, I guess, 7 to 10 years. And I'll touch up on that also. Otherwise, we think of young people as being invincible, and I see some invincible people out there. But once I always tell my patients, because I'm now starting to see, I've been in practice over 20 years. I decided to stop counting after 20. I've got third generations I'm seeing, but those people I probably don't see very often. If I see an 18-year-old, they go off to college, I might see them every 2 to 3 years. But my 40-plus-year-olds, I truly urge them to come once a year for a few different reasons. So, and then the 50-plus-year-old, definitely, I recommend that they come in once a year. One thing that we start at age 50 is colonoscopy. Yes, colonoscopy's got a bad rap. Nobody wants to get it done, but think of it as not just being a diagnostic test. It's also in some ways a therapeutic test, because when the gastroenterologist is in there, not only are they looking for cancer, they're also looking for polyps. And if they find polyps, some of these polyps are precancerous. They take them out. One more thing to remember is I was actually trying to find the incidence of colon cancer in the Indian American population. It's actually not very high in India, but it is actually more common in females than males in India. However, I will caution us all that our diets are not what our Indian diet used to be, 30, 40, whatever, 50 years ago when we came to this country. Our diets are now Americanized. So our incidence, unfortunately, I think has gone up. I am sorry, but I couldn't find an exact number for you folks. So that I think is a good test. The USPSTF does recommend one more testing, or instead of colonoscopy, which is a colon cancer, a stool occult blood test. It's an immunoglobulin-based test, and that actually is also recommended to be done every year. But this is what I end up doing in my practice. When I see a 50-year-old who is waffling, is unlikely to go get their colonoscopy, I give them the option of that stool test, which they might do for a couple of years. Then I'm leaning on them saying, please go get your colonoscopy done, because then I explain to them the need to do that. So if you've got somebody who absolutely refuses to get their colonoscopy done, at least they should go in for a stool test every year. Do remember that if that stool test came up positive, then for sure they need that colonoscopy. But sometimes people do need that incentive. And one thing, Juliana and I were talking, people of Indian origin, we are relatively reluctant to get too many tests done. We don't want to go in for too many procedures. And so I understand that. So maybe, start off with a stool test and then move on to a colonoscopy. For ladies, the USPSTF guidelines for people, women over the age of 50 is mammogram every 1 to 2 years. Now, that's actually a change. They had recommended mammograms every single year. Also, ladies who are at risk because they've got a family history should absolutely go in every year. Once in a while, we have hedged and we have said 1.5 years. And so, but on a routine, semi-routine basis, these are women who usually have either in their 40s also is recommended. They either have really small children or children of a certain age. You've all heard that finding a cancer early helps with treatment better. And so another reason to maybe have them go in for a colonoscopy. And then I talked about annual exams. Definitely after 50, it's a very good idea, because what are we checking? We are also checking, the blood pressures, which we heard is, high blood pressure. When I talk about high blood pressure, I say everybody 95% of the people by age 95 will have high blood pressure. As we get older, the number of people with high blood pressure will actually increase. And so if you go into the doctor is warning you, your pressure is going up, maybe you talk about lifestyle changes that you might be able to do to bring your pressure down. Maybe it's lifestyle changes plus medication that they are recommending. And so definitely a good idea to go in for annual exams. We'll come back to annual exams because there are a couple other things that I do want to also mention. So I talked about the cervical cancer screening. So pap smears with HPV every 5 years. Do remember, though, not all doctors have bought into that HPV testing. And so there might be doctors who might say come back every 2 to 3 years, which if they don't do HPV testing, that makes sense. The other thing I will say is we also do something called a pelvic exam, where we are checking for the size of the uterus, the ovaries, all that stuff. And that probably needs to be done every couple of years anyway. So I go back to my thinking that a 50-plus-year-old probably should come in to see their primary care physician every year. And then this actually, I don't know if anybody has heard about PSA. So PSA, I see some people nodding their heads. There has been a lot of press given to the PSA. There was a time when we ordered PSA on every man over the age of 50. Then we stopped ordering it completely because those were the recommendations. And I think the pendulum's kind of swung into the middle now, where I'm talking to my patients about it. We are talking about their risks. If they have a family history, it's every year. If it's not, then maybe we are looking at their symptoms. And I think on an average, I'm ordering a PSA every 2 to 3 years now. And then, so PSA is prostate-specific antigen. It's a substance that's released by the prostate. And when we see prostate cancer, the level is typically very high. But the other thing we are also looking at is the velocity of it. If I had somebody with a PSA of 0.6 today, and then a year later or 2 years later is now 4, that is cause for concern for me, even though the 4 is still within normal range. So the velocity of increase is also something that we think about when we do order PSAs. The other thing to bring up, a quick question, because I think we are holding questions to the end.
Understand.
Shall we hold it till the end?
That's okay.
Okay.
Thank you.
Thank you for that. And so one more thing to bring up is the DRE, which is the digital rectal exam. Again, the guidelines have gone back and forth. I tend to end up doing a digital rectal exam every year, every 2 years. And what are we looking for? When we're doing a digital rectal exam, we're looking for any lumps on the prostate. And so if we do feel something like that, then that's cause for concern for us. But I will tell you, the USPSTF isn't very keen on digital rectal exams. Just as they are not keen on women doing breast self-exams. So the self-exams, again, back and forth, we've gone back and forth. Yes. When I was at Stanford, we said, got to do it. We want to make sure we are teaching our patients to do it. And then we said, oh, no, it's no good. So we've gone back and forth. In my experience, women who do a breast exam and come in with a lump because they know what their breast feels like, actually often come in with a worrisome lump. So my patients get told, please do a breast exam every month. A couple more things to bring up. Now we are up to age 65. So in addition to everything else that we talked about, So the colonoscopy, the mammograms, good ideas. Cervical cancer screening, believe it or not, actually falls off the list at age 65 for females, which is unusual. But cervical cancer is actually a younger woman's disease. Most women pick up HPV in their 20s, and it becomes a problem in their 40s or even late 40s. So if we were to see an abnormal pap, it would be before the age of 50. And so current recommendations from the USPSTF are no pap smears beyond 65. However, if you've got a family member who is having a symptoms or a friend who's having a symptom, by all means, they need to go see their PCP ASAP, because just because the guideline isn't there doesn't mean you would not check if they were having a symptom. Then that particular testing becomes symptom related. So one thing that we do at age 65 is we start recommending eye exams. Now, I'll pick on somebody. How often should diabetics do eye exams? Have you heard? Do you know? Every year. Exactly, every year. So the reason for that is we can see changes in the retina, which is the seeing part of the eye, because the blood sugar, high blood sugars can actually affect the seeing part of the eye. So unfortunately, people can have either strokes in their eye or something called diabetic retinopathy, which can unfortunately lead to blindness. And in this day and age, in this country, there is a lot that the retina specialist actually, by then the person seeing a retina specialist can do to help with that problem. Again, why are we doing all this? Yes, we want to have people live longer, but more importantly, in my mind, the reason why we do all this is to keep the quality of life good. We are doing all this to keep people from having good, productive, enjoyable lives. So, and then, there are people who are at risk for, well, as we get older, we are all at risk for glaucoma. But then some people have a really strong family history and they're even more at risk for glaucoma. So that's another thing that they will check. And glaucoma is where the pressure in your eye gets higher. It is not always correlated with hypertension, but it's just the pressure inside the eyeball. This actually is a big problem I see in my senior population, the hearing assessment. They know, well, sometimes they don't even know. They say everybody else is complaining, but they don't know, they don't think they have a problem. The question I ask them is, when you are there people here who have a problem? Usually, it's family members complaining to me, wife might complain about the husband or something like that. And the person says, I have no issues. So
TV is too loud.
Pardon me?
TV
is too loud. Yes, exactly. We can't sleep because his TV is too loud. Exactly, that's what I hear. So one thing I ask people is, how do you do when you are in an environment where there's a lot of ambient noise? Like if you went out to a restaurant with a family member, with your family, say, how do you do with hearing them at that? And then they say, oh, I had so much trouble with that. Well, there's a problem. You could not hear because you couldn't hear in that ambient noise. You couldn't hear your family members at the table talking to you. And so I am a big fan of hearing aids. I have personally never owned one. Maybe that's why I'm a big fan. But the reason I say that is, and I know the two doctors here are going to probably touch on that. I see a lot of people missing things, and then we think maybe they've got dementia, but really all it is that they can't hear you, and or they didn't hear that you told them that they need to go. They have a doctor's appointment, and now they're missing it because they never got ready. So if you've got older friends or family members who need to get their hearing tested, definitely let them know. Now, one more thing, since I'm a primary care physician, I deal with this with Medicare. Rina talked about the fact that we all need to understand the complexities of the U.S. medical system. Medicare, unfortunately, does not pay for hearing aids, and so it's an expense out of pocket at I think $4,000. which is like major jewelry. And so people are sometimes reluctant, and I can understand that. But I think the benefits of not of hearing are really great. And the same with the eye. So cataract surgeries. I will sometimes see a patient who is waffling on getting their eyes taken care of. That is one other surgery. So I'm very anti-surgery as a primary care physician. But this is one surgery. I think if people need it, they should go get it. It doesn't matter that they're 90 years old. I think they should go get it, because if they can't see and they can't hear, that's a really big loss, a big hole in their lives. And then we talk about bone health. So there are people, so women of Indian origin are high risk for osteoporosis. So I'll ask the ladies here, do they know if their mom has osteoporosis? See that? So it's very common for us to see, you might have your mom have osteoporosis. I think it's to do with our stature. We are under 5'4" oftentimes, and we weigh less than 127 pounds. I don't know why that arbitrary number, but that puts us at higher risk for osteoporosis. So what do I tell my 40 and 50-year-olds to do in addition to the stuff that's already on the list there? I'll take
exercise. Stress exercise.
Excellent.
Weight training.
Perfect.
Sunshine, milk.
So yes, so that would be the calcium and stuff, but that was what I was looking for is exercise. And aerobic exercise is good for a lot of other things, but this would be weight training. So that's another thing that I see a lot of people very reluctant to do is weight training. But I tell 80-year-olds they should start even at a pound, even a can of soup. If they can exercise, do some weight training.
Stop dancing.
Sorry, dancing.
Stop dancing.
Dancing would be very good exercise, aerobic, and help with your bones. And so definitely weight training, very good. In addition to, as you mentioned, calcium, and then vitamin D3. So this is what we are seeing with people in vitamin D3. Again, the USPSTF, sorry, I keep bringing them up. Their recommendation is actually not to check vitamin D every year. However, once we check it, once we've checked it, 99% of my people of Indian origin, because we have got the pigment, we don't change the D2 to D3 as well as we should. And so the recommendation is to take a supplement pretty much indefinitely. And so when I write my messages to patients, I say, please start on vitamin D3, 1,000 international units every day, indefinitely. The reason for that is every few months, in addition to the bone health, I see data that shows, the last one I saw, which I thought was very funny, I don't know if you guys saw this, was it helps protect you against respiratory illnesses. Really, but great. The other thing is a lot of cancers, breast cancer, for example, the recommendation is that we keep vitamin D levels, in good range. So if you've been told take vitamin D3, please just take it. Don't argue with your doctor, just take it. Good for you. The other thing is immunizations. So I have to tell you, I'm a big fan of vaccines, especially the vaccines that you take, infrequently. At a certain age, a flu shot is a very good idea. I'll take a show of hands. Who's had their flu shot so far? Good going. Excellent. The other vaccines that we do recommend are the tetanus shot. So tetanus shot, especially when we give it to, since 2005, we have been giving the tetanus, diphtheria, pertussis vaccine. Pertussis is whooping cough. You might have heard, we've had cases of whooping cough in this country, in this state, and of course, all over the world. And so that's why we give our, I talk about adults, but you give it to the babies also. We give a tetanus, tetanus, diphtheria, pertussis vaccine. People who've had the Tdap already, the recommendation is to give a TD, which is the tetanus and diphtheria vaccine. without the pertussis. The pertussis is recommended by the CDC only once in adult age. The second vaccine, the second two vaccines actually that I'm a big fan of are the pneumonia shots. So a lot of you might remember that we've had one pneumonia shot, which is the Pneumovax, the second name, which is a 23-valent vaccine, strep vaccine that I think has been around, I don't know, 20 years, maybe more. So we've been giving that to people over the age of 65 forever. There are people who are under the age of 65, if they have asthma, if they have kidney disease, if they have other chronic illnesses, heart disease, they get that vaccine, and then, but usually we give it at 65. The second pneumonia vaccine has probably been around 7 to 10 years. It's a 13-valent strep vaccine. This is how I explain pneumonia shots to patients. I say there are many different kinds of pneumonia: bacterial pneumonias, fungal pneumonias, viral pneumonias. Of the bacterial pneumonias, there is strep pneumonia, which is the most common one that we see, a very common one that we see. Who remembers Jim Henson? Muppets? He died from a strep pneumonia, pneumonia. And so of those strep pneumonia subtypes, we've got those two vaccines that we are recommending for our 65-plus-year-old crowd. They're given a year apart. So you give one. Nowadays, we give the Prevnar first, and a year later, we give the Pneumovax. So when you come in, when you're on Medicare, and you come in for your, it's called annual wellness exam, that's my chance to catch you all to give you those two vaccines. So a year later, I give you that other vaccine. So the shingles vaccine, there was an older one called Zostavax that was around for, I don't know, 7, 10 years. But it was unfortunately only 50% effective. I still recommended it to patients because if you personally had shingles, actually none of you are that old, but when I see my when I see my 80 and 90-year-olds get shingles, it is miserable. It is a really painful condition that goes on and on and on. And so the recommendation is that we recommend that vaccine. I was still telling people to take it till this one came out. Now we have a shingles vaccine called Shingrix. It's a 2-shot series. It is supposed to be 97% effective. So even the people who took Zostavax should really take this. Unfortunately, it's in short supply everywhere, all that stuff. But if you can lay your hands on it, take the vaccine. It's recommended now beyond 50. The old one was recommended beyond 65. This one's recommended beyond 50, and it's a 2-shot series. I say to be given one and then within 6 months. So I say easy way to remember. Take it, go back in 3 months, take the second one. And then travel vaccines. So this is not routine for us, but in the Bay Area, I have patients who send me a message and say, Dr. Sukhdev, I'm going to Vietnam next week for work. And because people are traveling so much, I try very hard to keep them immunized with hepatitis A. So hepatitis A is a viral illness that you can get from food and water. You do not want hepatitis A messing up your vacation or your work in Vietnam. This is a good vaccine to take. All the kids in this country who are, I don't know, under 30, under 29, 28, something in there, were immunized. Either they had a catch-up, and I think the 25 less, you might know the dates, the 25 and under, I'm going with what my kids are, they were all immunized actually almost at birth. So the kids are immunized. It's for the rest of us to worry about. Also, if you went to, this is my thing that I ask patients who say are of Indian origin, did you stay in a hostel? Did you stay in a dorm? If the answer is yes, hygiene was so bad there, it's very likely you were exposed. Or if they give me a history of having had jaundice, then they probably don't need it. We can also do we can check an immunity test for people. And so that's another vaccine that I do strongly urge people to take if they haven't taken it already. And the last one that routinely people get is typhoid. So typhoid is an injectable vaccine, or there's also an oral vaccine. And now I'm kind of going into the travel mode, so I'll make mention of a couple other things. A lot of people take malaria prophylaxis, which is where you take, there's one that's recommended now is a pill that you take every day. You take it a day before you leave, while you're in the malaria area, and then for 7 days after you come back. But who's heard of chikungunya or dengue? A lot of people. Unfortunately, the only thing that protects you against that is keeping away from mosquitoes. So a mosquito net is probably the best option at that point, or repellent, long sleeves, all that stuff that you heard about. We have no medications to prevent those two illnesses. And believe me, I've seen patients come back with fevers of 102, 103 because they had dengue. Actually, I had a patient with dengue and chikungunya, poor lady. It was a very, very difficult. These are not diseases that thankfully kill. Actually, dengue can. But you can't go to work for 2 months. You're awfully laid up. If you're traveling, be careful. If you go to India, make sure the uncle or aunt or mom or dad, they've got mosquito nets for you. I think that's probably the best thing to do. BMI. I'll take a show of hands. Who knows what a BMI is? Lots of people. Nice. So BMI is body mass index. That's how well your weight correlates to your height. So this is what I tell people. Nobody here qualifies, but there's a Dr. Sigdev's rule, which is nobody should weigh more than 200 pounds. Really, there's no reason why somebody should weigh that much. If they weigh that much, I say, next time I see you, you better be taller. Or remember, I only see adults, so 18 and over, there's no way they're getting taller. So they get the message loud and clear, they should lose weight. So for regular, the categories, underweight is under 18.5, which is not usually a problem I see. Normal weight, overweight, or a BMI of more than 30, which is obesity. Actually, the guide, there are some data that says for people of Indian origin, or actually all, not just South Asian, not Indian, but even, all Asian people, the numbers should be a little bit different. Like it should be, 23, up to 23 being normal weight. But I try to make it easy for you. If you will be seeing these, if you Google BMI, this is what you'll see. So you can plug in your height and your weight, and it will tell you your BMI. Most of us were a BMI of 18 or 19 when we were 20, 25. And then over time, people gain weight. The ladies tell me, oh, it's since I had children. I say, really? No, you're right. I lost all the weight and then I gained some back. So most people get to a BMI of, you get to a BMI of 25 by age 40. But if you're over that, then you're overweight. So, and this is the root of a lot of problems. I know, Sharina, you brought up obesity. That is a lot of our problem, is the fact that a lot of us are overweight and obese. And if we could only fix that problem, that would make for healthy aging. One thing I bring, which is not in any textbook or any guideline, is when I see my 40-year-olds really making an effort. So 20s and 30s, we are all crazy busy. The children are growing up. You're trying to work on your career. There's no time. But 40s, life kind of settles down. And so you start to say, now is my time to start exercising. My sister, who's in her 40s now, told me today she went to a Zumba class, and then tomorrow she's going to a weight training class. I said, yay, finally. All this stuff I've been talking to you for years is now settling in. So beyond 40, we should all try to work on, keeping our weights down. If we can get our weight down, if we take care of our bodies in our 40s, then we will have, the golden years, right? You heard about the golden years. We'll have good retirement. We'll have good 50s. Well, 50s will be probably okay. Good 60s and 70s and 80s, and if we get into the 90s, then good 90s. So this is probably the most critical thing to remember. If people can lose weight and get into their ideal body weight range, that makes everything. So everybody in this room either knows somebody who is diabetic, has family members who are diabetic, or is themselves pre-diabetic. So when I was a kid growing up in India, I had all my relatives were skinny. Now I go back, they've got a car in their driveway, and they're eating Pizza Hut or Domino's, that's a big thing, and they're all now overweight or obese. I don't remember seeing an obese person in India, at least not that I knew of when I lived there 30 years ago. But now we see a lot of that. And what does that lead to? That leads to diabetes. So I just wanted to touch on a few principles of diabetic care. So there's a test called hemoglobin A1C, which actually, it seems in India, again, I left many years ago, is not something that's recommended that routinely, but in this country, we would check it at least a couple times a year, maybe more, depending on what is going on with that person. So I want you to be familiar with this name, hemoglobin A1C or A1C. It's a percent, and it's a very sophisticated test. It's checked in red blood cells, which have a lifespan of 3 months, which is how the 3-month average sugar. It's also my test to make sure that people aren't lying to me. So they will behave for 2 weeks before they come to see Dr. Sakhdev, because yes, she will be mean to me, which I'm not mean ever. But their A1C is a 3-month average sugar. So then I say, oh, you were good for the last 2 weeks maybe, but 3 months ago you weren't that good. And so the goal is less than 7 for as a guideline. However, if I have a 40-year-old, I am not looking for less than 7. I'm looking for close to 6. If I have a 50-year-old, I am not looking for 7. I'm looking for 6.5 or less. And why do I get tough with these people? The reason for that is because if you look at most of our data is from the UKPDS. If you look at that big study that was done, I don't know, 20 years ago, 17 years ago, a long time ago, the tighter the blood sugar control, the less complications people had. And so that's why we are very careful. And I try and keep my younger people, their blood sugars under control even better than, So once they're over 70, hemoglobin A1C of 7 is great. In fact, there's data to show that very tight control is actually not good. But under 70, tighter control as much as possible. You guys knew about this, eye exam every year, a foot exam. Why do we do a foot exam? Neuropathy, did I hear that? Yes, exactly. So neuropathy, diabetic neuropathy. So what happens when people get neuropathy is they don't feel that they might have had an injury, then it becomes an infection, and unfortunately that can lead to amputations. So that's why we check once a year to see. And I will tell patients, you're losing sensation. Let's see what kind of shoes you're wearing. Falling is not a good option. I need you to now start looking at your feet every day to see if you have any injuries. So that's why we do a foot exam, typically, a couple of times a year, but at least once a year. And then I brought up the vaccinations. Remember, for diabetics, we are giving them that pneumonia shot ahead of time, earlier than the 65. And then diet. It's all diet, right? So I'll come back to that if time permits. But that is one more thing I want to really bring up for you all is diet. So physical activity. What is our current recommendation? How often? What is the recommendation from the CDC now? Does anybody know?
30 minutes a day.
30 minutes a day, 5 days a week.
Correct. Very good. You're well informed. However, if you were a Dr. Sakhdev's patient, I would say 30 days, 5 to 7 days. Because, not doing it for a couple more days, but 5 days, if you can do 30 minutes, that's excellent. And what are we looking at? We are looking at aerobic exercise and a little bit of weight training. Now, somebody will say, I do 45 minutes or an hour and a half, 2 or 3 times a week. Well, that's better than nothing, but just think of it. We are eating every day. We really should be exercising every day. So something every day is definitely a very good idea. Metformin. it came out in, I think, about 23 years ago. Good stuff. People of Indian origin, we have a gene called the thrifty gene, where we hold on to carbohydrates. And if we, and that's how we gain weight. Metformin helps our body process sugar better. So it's a good medication to be on. Please do not be afraid of metformin. It's really, really good for us. It's a, especially for people of Indian origin, it's a good medication to be on. Once in a while, I'll have somebody who does not tolerate it, but I always start slow. So I start with 500 milligrams, maybe with dinner, and then, add more doses if needed. People tolerate 1 to 2 doses for sure. They may not tolerate the top 4 pills per day. That is often recommended. But if you can even do 2 pills a day, well, you should listen to your doctor. But most people, tolerate that okay. Also remember, metformin, if you take it with food, you'll tolerate it better. Bariatric surgery. Who knows what that is? So weight loss surgery, bariatric surgery is weight loss surgery. So, 20 plus years ago, I would talk people out of it. I would say, don't do it. It's got lots of complications. It's probably not going to be a healthy life from there on. Now the procedures are sparing the stomach a lot more, and people actually do okay. Now remember, none of the people who are recommended that are the really morbidly obese ones, whose BMI is over 40, or if they're over 30, then they have to be diabetic or some other complication from the obesity. So it's not something that we will tell every patient to do, but it's a select group of patients. But I did want to put it up there because if there's somebody who's really morbidly obese, again, we are all averse to surgery. I'm one of them, but it may not be a bad idea. It might actually keep them alive if they were to do it. So next big thing that we all deal with, hypertension. So these are the American College of Cardiology blood pressure guidelines. We are really looking for blood pressures of 120 to 129 systolic and diastolic of 80. So we all know systolic is the top number, right? When you get your blood pressure taken, they'll say your blood pressure was 120 over 76. The 120 is the systolic, the diastolic is the bottom number. I have patients asking me, which is the more important, the systolic or the diastolic? They're both important. We go after both of them. One thing I will say is that the older patients, so not even 70, more like 80 plus, I try not to bring the pressure down so much, even though the guidelines again have gone back and forth on that, because I see people, more at risk of falling from being lightheaded if we get their pressure down. But for the rest of us, I don't see anybody here over 80. The rest of us, I think it's very important to see if our blood pressure is 120 or 129 systolic and 80 diastolic or less. So how do we get these? How do we get the blood pressure down?
Meditation, exercise.
Meditation, exercise.
Low sodium.
Low sodium, very good. So stress relief, which we haven't touched on. You're probably all more better experts at that than I am. But I actually tell patients, especially beyond 40, again, I can come back to 40. I see a lot more people having trouble with stress-related symptoms. In Silicon Valley, I mean, it doesn't matter what we do here for work. We could be doing anything, but it's extremely stressful to live here. So definitely beyond 40, meditation, good idea. Exercise. Exercise makes endorphins, which are the body's natural feel-good substances. And so another very good form of stress reduction. Nobody said medication, so I'll say that. Drugs, medications. We have got some very good medications. So when I was in medical school, we could not have said that. Now I say this to a patient. I'll say, I will find you a medication that will work for you to reduce your blood pressure, but also not give you a side effect. Because we've got so many different drugs classes that we can. if I have a patient who is diabetic or pre-diabetic and they have high blood pressure, there's a class of drugs that I prescribe, which is ACE inhibitors, which would be like lisinopril, benazepril, like Lotensin or Prinavil. Good medications for kidney protection, in addition to the fact that they are heart healthy and very good blood pressure medications. So the goal for us is blood pressure of less than 120, preferably less than 120, definitely less than 130. Okay, I'm picking on you two again. What's heart disease? You can read it off there.
You're talking to me?
Yes, sir.
I'm sorry, I was not paying attention.
I used to be a professor. I do this all the time. So heart disease is where there is reduced blood supply to the heart, right?
Yes.
Yeah. And how about a stroke? Do you want to tell us what a stroke
Stroke
is?
also can lead to, yes.
So stroke is where there's reduced blood supply to the brain,
To the
right?
brain.
Or ischemia.
Ischemia or hemorrhage or whatever the reason may be. When it's happening in the brain,
What's ischemia?
ischemia is reduced blood supply.
Reduced blood.
It's a reduction in the flow to the heart, ischemia.
Is heart disease. Ischemia is anywhere. Reduction of blood supply to the kidney is kidney ischemia.
Oh,
So heart ischemia or where there's damage now to the heart muscle wall, the wall is called a heart attack, whereas a stroke happens in the brain. Same pathology, same cause exactly, but it's happening in the brain. So those are two different conditions that we talk about. And this is, I'm sorry, a busy slide, but I did want to put it all on one thing because I actually teach a class for seniors where I calculate everybody's risk factor. So this is the American College of Cardiology risk calculator for heart disease or stroke. A 10-year risk is what we calculate based on these factors. So age, males have a higher incidence. Indian Americans, as we've heard, have a higher incidence. What your total cholesterol is, what your HDL cholesterol is. HDL cholesterol. Sir, what's HDL cholesterol?
High density.
Lipoprotein. That's the good cholesterol. We want that number to be as high as possible. We actually run into trouble. People of Indian origin, we have low you know that. We have unfortunately low HDL. HDL is where it's HDL cholesterol is really, it's cardioprotective. We need it to literally take out cholesterol from our arteries and take it to the liver and process it. So HDL is good cholesterol. We need high good cholesterol. Systolic blood pressure, you're experts in that now. Diastolic blood pressure, if they're on medication for blood pressure, if they're diabetic, and if they're a smoker. So smoking defies all logic. If I have a patient who has family history of early heart disease and they're a smoker, I'm walking on eggshells with them because smoking is probably really, really bad for you when it comes to heart disease and stroke. But the other thing that's really a problem is your systolic blood pressure. So I didn't have a chance to give this slide in time, but I'm going to put some numbers on there. So let's have a 60-year-old man, right, age, gender, of Indian origin, total cholesterol of 200, HDL cholesterol of 32, not unusual in people of Indian origin. I see HDLs of 19 sometimes. Systolic blood pressure of 150. Most people won't think 150 is that high. Diastolic blood pressure of 90. Most people won't think that's that high.
This used to be okay a few years back, right?
See that it's changing, you're right. But one thing that has not changed is, especially in younger patients, we are still looking for lower numbers. That person is treated for blood pressure, not diabetic and non-smoker. And I did this calculation earlier today, and so I'll tell you, their 10-year risk is 15.1%. If I kept
what does that mean, I guess?
Oh, so they have a 15.1% chance of having a heart attack or a stroke in the next 10 years.
15.1%.
Well, 15%.
How is that different from the Framingham?
Very good, very good. You know Framingham. So the Framingham, for people who don't know, I train at UMass down the street. But no, Framingham, I said like the diabetic stuff, most of our information is from the UK PDS. For cholesterol, most of our information is from the Framingham trials. This is a city in Massachusetts where they've done prospective studies where they've enrolled, I think they're enrolling their 4th generation now, and they've looked at how people's blood pressures and cholesterols and diet and huge amount of data. So the Framingham risk calculator is probably a very
There's no
simple.
race in it.
And actually that is very important.
Yeah. That's probably the biggest difference here.
Yeah, the American College of Cardiology came out with this in 2014. I think 2014, yeah. So
I want to go back to that 15% number.
yeah,
Is it 15% more than the normal, or is it
Absolutely.
absolute, or what? How do I treat that number, 15%?
so I think it's a 15% for that person. If you were able to bring it down, where you
So
let's
then
say-
normally you would like 0.
correct, or less than 7.5.
Less
Single digit is okay. Double digit, 15 becomes kind of something to worry about.
So I'm saying, looking
Sure,
at incremental, because of all these factors, how much does it add?
Yeah. So let me tell you one more thing, and then maybe a little bit more clear. So then I plugged in another set of numbers, changing only their systolic blood pressure from 150 over 90 to 120 over 80, and the risk went down to 10%. So controlling, and this was only one thing that I
One thing,
changed.
yeah.
If you're going to remember, I talked about BMI. The other thing, the other thing I want you to remember is high blood pressure. Be very careful with your blood pressure. So, diet. This is what should be on our plate. I don't see any gulab jamun on there.
Carbohydrate, right?
Well, that's a dessert. So carbohydrate is missing, right? No, it's missing. But the carbohydrate would be, if I said carbohydrate, most of you are thinking chapati, rice.
Aloo,
Exactly. However, actually I should have brought, I have these plates in my office that I show my patients. Half your plate, this is how we should be eating. Everybody over the age of, all adults, right? Everybody over 18. I don't know about kids. Like I said, kids scare me. I do have 2 and I scare them. So salads and vegetables, half your plate should be salad and vegetables. 1/4 proteins and 1/4 carbs. So what are the different kinds of proteins that you eat?
chicken and fish and stuff like that.
Chicken, fish,
Dal.
dal, tofu, very good.
Milk, I guess,
Paneer.
cheese.
Paneer. I have a little bit of trouble with paneer because I don't like. Yeah, because it's relatively high in fat unless you make it at home and you make it low fat. But yes, paneer. And nuts.
What about the 5
Nuts.
dozen the fruit every day?
Nuts.
Nuts.
Nuts and
Eggs.
fruits. Yeah, no fruits there.
So you bring up a good point. So everybody has heard of 5 a day, right? You've heard a saying, please eat 5 a day, fruits and vegetables. Everybody here is an adult. What I would say is 3 servings of vegetables and 2 servings of fruit for you guys. Maybe children can eat 5, I don't know. But for adults, 3 servings of vegetables and 2 of fruit. What's the serving size of a fruit? Remember that big banana you get in America? Half. Half of that is a serving size for an adult.
I think your fish size is your serving size.
Yeah, so that would be more for rice, or you brought up chicken and fish. The palm of your hand, that would be good for chicken and fish. The only thing with dal, whoever said dal, I'll say is, dal unfortunately has carbs
Yes.
in addition to protein. Nobody said chana, nobody said moong,
Yeah.
all of those sprouted.
Legumes.
Very good.
Legumes.
Legumes, very good. So all of those are good sources of protein. The only problem is a lot of them have some carb in it in addition. So I think if we can cut back the amount of carbohydrate we are eating, eat fair amount of protein and eat, salads and sabji, that's a better diet for us. My mother and I argue about this. She says Indian diet is very balanced, and she's vegetarian. And I say yes, it was very balanced and very good when we walked. Now, I go into my garage or my driveway to get my car, and we are not as active.
Right.
So that old, eating 2 or 3 chapatis, unless you are, training for a marathon or something, we all should not be eating as much carbohydrates. So there's no dessert on there. I would never tell anybody not to eat ever eat any dessert, but be very careful. If you ate dessert today, please don't eat anymore. I think my time is up. Thank you all. You were a great audience.
Next, we have Dr. Rita Bhatta, who is a gerontologist. She'll be talking about healthy aging for the mind.
So that was a brilliant talk. Thank you so much. We learned so much about the healthy, the body. And I just, so this is the page you see. So I just want to spend 1 or 2 minutes just getting to know each other. And I feel that today's talk being on aging, what we call successful aging, successful mind, I think that I'm assuming that all of you here are here because you're counselors, you're learning about the Bhagavad Gita, our tradition, but I think you're going to be taking all this information to probably do something moving forward, whether you're working with adults or older adults, younger adults, you're creating infrastructure, whatever it is. But the fact that you've decided to have aging as a topic, I felt that I'm going to take you to a different side of aging where, as the way we see it every day and the way probably you all experience it. So just talking about what I have done, I came into this country many years ago, and my father was a scientist in Delhi, and I saw him at a pretty early age have Parkinson's disease. And I saw what that disease did to him. I saw what that disease did to our family in terms of hopes and how to plan. So we understood the treatment, we understood what was in play, but what did it really do to us? And then after coming here, I branched into gerontology. I did my postdoc at Stanford. And ever since, I think for the last, I would say every single decade, I've been here for almost 35 years. I first had my father's illness, and my mother died of stroke. And then my husband, who's an only child from southern India, his parents came to live with us. My mother-in-law passed away with breast cancer after a 10-year fight. And now my father-in-law, who's actually has followed, Dr. Sukhdev, a lot of your styles, a lot of these health benefits, came to live with us and is living with us. And he had a fall while walking. And he's a journalist from a place called Tenali in India. And we saw what that fall did to him. It kind of got us to the brink of what Dr. Mehra is going to talk about, palliative care and hospice. He's currently on palliative care, but needing 24-hour assistance. And I've seen what that has done to his personality, his aspirations. And so when you talk about aging, there are so many aspects that kind of come into this area. What I understood from actually one of your individuals, Mangala here, that your role is as future counselors in society. And how many of you I know have aging parents that you're dealing with, whether here or in India? So few of you, okay. And how many of you are just interested in this field of aging? That's great. Okay, good. All right. So aging is not a disease. If there's one thing you can remember, is aging is not a disease. And I'll tell you why. Whichever area you go into, you will realize that some of us may not get married, some of us may not have children, but every one of us has a parent. And you too will be a parent. So aging, if you kind of, this whole aspect of thinking about aging as decline and deformity or disability, that era has kind of gone away. So average age expectancy, as Dr. Kapoor said, has tremendously escalated. And you have all these reasons which everybody has discussed, technology, better care. When I first started my career, I remember I would lose a great deal of my patients just to heart attack or some kind of a sepsis or some infection. But now they don't. We just get readmission after readmission and people live through. So what's happening is that we are living much longer. Most of us, as Dr. Satdev said, is very healthy, but many of us will probably will not. So the few things to remember is aging is unstoppable. No matter what ads you see on TV, no matter what you buy. And I remember this very famous professor of dermatology at Stanford. He told me, he says, Rita, people spend $500 on this cream. But if you take Crisco oil and, the greatest amount of kind of the oil in it, that's good enough. So we are fighting for aging, and we are fighting for another professor of mine recently told me, I have a new knee, I have a new hip, but I don't have a new brain yet. So we are all kind of, aging is unstoppable. Unfortunately, you and I are going to age. And we have to see how the world treats us, what the world is like. But it can be varied. Aging can be varied if you take precaution. So the genes we don't know much about, we can't help much. Some of the genes kind of impact what we're going to do. But the lifestyle, which you heard the previous speaker talk about, you talk about access. So I'm going to talk a little bit about access to care, how some of the behaviors can be very important. So what is successful aging? Now, in a short period of time, I think some of you have already understood what is successful aging, but what is it that we can really come to a conclusion with together? Healthy body, sound mind. That's what everybody says. We all want to live with healthy body, sound mind. None of us really want to live with disability. We don't want all of that. However, those are some of our grim realities. Absence of disease and disability. Purpose and engagement. So I started a series of experiments when I came first from India, and I interviewed a lot of our professors, some of them from India, some mostly from Stanford, some from Berkeley, and I interviewed them when they were in their 50s, 60s, and 70s, and some of them I have now re-interviewed, which I'm kind of writing a book on, and I realized that one of the fundamental things everybody told me as they age is they said, Rita, I need purpose and I need engagement of life. I think that's the thing that helps us get up in the morning. You can sometimes have purpose and engagement. Some people have it naturally. For some people, it has to be developed. So I was looking through, scrolling through, because my father-in-law is very much, he reads the Vedas and he translates it. And I saw something which is very interesting. Spending the remaining years becoming fearful of approaching death and thinking that one is useless is the greatest misfortune. So you have the capacity now, you own whatever you have, you take charge, and you move forward. And I'll explain this. It's a very simple example that a previous speaker spoke about osteoporosis. I think many women in India have it. I lost my mother to it because she had a stroke, plus she had osteoporosis. My older sister has it. So when I was doing my baseline study so many years ago, before I had my daughter, I went to the doctor and they said, tell me about your health history. And they found out I'm from a family with severe osteoporosis history. So they said, take charge today. So if you take charge today to move forward, so I did that. I followed with exercise, I followed with vitamin D, I followed with diet, and today I have a very high vitamin D count, which helps in that. So some amount of constructive behavior is part of discipline, is a part of how we move forward. So I teach a course for nurses and medical students. So this kind of, sort of makes you sit up a little bit, because we've all had lunch and we're in a class and we can tend to kind of get distracted. So I'm just going to run through, just say true or false, the first thing that comes to your mind. So most past 65 have Alzheimer's disease. False. Okay. Intelligence declines significantly as you age. False. Memory loss is a normal part of aging. True. True. Some people said true. Okay, this is what we're going to come back. That's the part of our talk today. Okay, but it's actually the answer is false, because memory loss is not a part of normal aging. That's the part that we are talking today, which is cognitive dysfunction or dementia. As adults grow older, reaction time increases. True or false? True. Very true. So when you press that brake in the car, or when you reach for something, the reaction time tends to increase. Okay? Clinical depression is more frequent in older adults. Yes,
False.
true.
True, I'm sorry.
It's actually false. Okay, so this is because clinical depression happens because of a fundamental, series of constructs that take place, and we can talk about this a little later. Fewer face acute conditions, so you have more acute than chronic. Is that true or false? So what is acute? Acute disease is suddenly having a heart disease or suddenly having a particular, health issue. Chronic is what our previous speaker, which most of us have by the time we are 50, high blood pressure. So true.
True and false.
Well, we face more chronic disease as we age. Retirement, people become ill and die.
That's true. I guess people do become ill and die.
So that's so I think, sir, you made up a great point, because that's the whole idea, that do you let yourself get ill and die, or then do you take charge? Because we are talking about our second time of life with
The reason I agree with him in a certain sense is that if a person is 80 years of age, nobody expects him to keep living for another 100 years or 60 years or 50 years.
Right.
Whereas if somebody is 20 years of age,
Sure.
he's expected to live for.
That's a good point. It's a good point.
So this statement, I think, is correct. What is wrong with that statement?
But here's the thing, you have to check it in the context of where we are.
In the right context, you are right too.
You're right. You're very right. So in terms of actual numbers, you may be right. But retirement by itself does not mean that you're.
No. That is not the condition that is stated here. Now you have put forth an extra condition. In fact, this is my question.
But I will go with this. You are tired or retired? If you are tired, then you are retired. If you are not tired, then you are not retired.
Your mind is, in the sense of what you said there about.
I think you got a very valid point. I think this is a point we should discuss during the.
We have a Q&A at the end. We have a Q&A session at the end.
This is a very good point, actually. And a lot of my professors do bring that up. So are you less anxious about death versus middle-aged adults? Is that true or false, you think?
When you say you,
I don't know. I'm not
Less
sure.
anxious?
One way or the other.
Okay, so the answers
There
are
are
all
young
at the end.
fellows who say, "Oh, my,
acceptance of
I'm
mortality."
becoming old.
Yes.
I'm going," and there are older people.
Right. So the answer here, so we have the
I don't know
test
what to
results.
say for this.
Okay, so let's keep that till we discuss, and we have the answers later on. More spiritual as they grow older.
Yeah.
hopefully,
Probably correct.
hopefully, I would say that.
Tendency.
Happier if allowed to disengage from society. And remember, this is a very quiz that has been in existence for a long time. Okay, good. And then females exhibit better healthcare practices.
But isn't 42 really
It's true. There is a reason for that as well. There's a reason for that. Okay, now that I've got everybody sufficiently woken up and into the thing. So working with and helping older adults, this is what I understood today's talk was about, that how do we help, because you probably in this room know more than I do about many of these things that I'm talking about. So how is it that we can help you work with older adults, and what are some of the ideas we can bring to the table? So the facts for counselors, I think when you are dealing with older adults, I think one very important factor our previous speaker said is that if somebody has hearing loss, simply shouting or being louder doesn't help. Coming down to their level, kind of coming to the eyes level, this is how we were taught to work with older adults. Respect, empathy, and compassion are vital. And why is that? Because, when you imagine yourselves to be in their shoes, it is important, because chances are they may have had some losses, some changes in health. So it's very important for empathy, which is different from sympathy, to be able to put yourself in their shoes and see how life is and that perspective. So if you choose to work with this population, then this is an important trait. Know your feelings about aging. A lot of people, especially in the medical sense, in the hospitals, I have a lot of colleagues who tell me, I'm okay to work with babies and younger adults, but I can't work with older adults. And many times it can go opposite. Sometimes working with an older adult can cause some changes in us because we may see our parents in them. We may be thinking about our own mortality. If we are dealing with very robust, active individuals, that's one thing. If it's an older individual. So it's very important you take a few minutes and think about your own feelings about how do you feel about aging yourself or in others. Elders have greater wisdom, happiness, purpose, and contribute meaningfully. Now, this has been proved again and again. And if you want some research evidence, look at the Stanford Center on Longevity. There's a huge amount of information coming out that older adults actually have greater happiness. They report greater wisdom, and they can contribute extremely meaningfully. However, here is a point that I have to make, which kind of gets into this argument or discussion we have about retirement. Is society actually prepared to give people a chance?
Right.
Because if you look at today what's happening, and I'm now in private practice where I have a lot of older adults who come and say that I would love to work in a company or I would love to do something. However, I'm kind of being pushed out by the new age or the
Right.
millennials. And because it's different, it's a different world. So do you have actually prolonged life? So there's this very famous economics professor who's written this book, and they said that we have increased longevity by 20 to 30 years. But have we really created a society where all these people will feel worthwhile, respected, contributing? Have we done that? And that's probably a venture that we need to move forward to. Those with health issues, as long as you're healthy, you have economic benefits, you're able to access care, you have a good family, good brain, it's good. But if you have health issues or dementia, chances are you may become isolated. And caregivers of older adults, very often we forget the caregivers. We forget the wife that's taking care of the husband, or the husband that's taking care of the wife, or the adult children. Like, we are doing a lot of caregiver research and finding that typically it's the daughter or the women in their early 40s or late 30s who are taking care of parents and children, the sandwich generation. So caregivers are needing a huge amount of support. So what are the risk factors of aging? I think we've already discussed those. I'm not going to spend time because you understand, we had such a wonderful lecture just now. But some of them, like a fall can be a game changer. And if you look at medical reports from Medicare and Medicaid, that a fall is so expensive because at a particular age, if you fall, of course, one cannot prevent a fall, but you can be careful, and we get into other exercises about home safety and the blood pressure issue that you just mentioned, and whatever it is. I mean, I'm living with someone that had a fall and had a whole lifestyle change. But the fall can also be difficult for a hospital trip because you can have, other medical conditions like delirium, and then sometimes you don't recover too well, and there are all those other issues. Emergency room trips, I always caution, having worked 22 years in a hospital, emergency rooms, and that's a whole other lecture, but be careful if you are knowing someone, because emergency rooms can actually have a pretty negative effect. If I have the time, I'll talk about it. Living alone or being ignored. If you look around you, like I live in a place where I find that I have a lot of people in my area who are living alone, older adults, pretty isolated. Probably the only one visiting them is either the mailman or an occasional family. And these are the people who are kind of at risk. The other risk factor for aging, too many medications. I'm sure many of you realize that. And what we tend to do in the system here is we give medication for side effects and more medications. And I recently came back from India. My uncle was unwell, and he was hospitalized for a lung infection. And they gave him so many more medications that it had so many other side effects that by the time he came back home, he had, completely an altered health history. So medications, remember the other factor, I don't know if most of you recognize the merit of this, that many medications were not tested on older adults. So as we get older, we have different body, we have different metabolic rates. We don't have that much of water in our bodies. We are probably thinner. And so those medications can have a pretty drastic effect, as we see in older adults. And then to access to care. So you can plan a great treatment plan. And this is what happens to many people I work with, but they could not make it to a doctor's visit for whatever reason, or they did not have the medications readily available. And if you are in the area to create some of these infrastructure, then I would say that's something to look at. Low health literacy, a lot of people just don't get the medical language that they've been told to. And living alone, another risk factor. So the bulk of the talk today that I was supposed to talk about is cognition, and it's a difficult area to kind of go into, but what is cognition? The word cognition, if you look at the dictionary, it just means thinking. It's who you are, your perception, knowledge, memory, judgment, and there are these tests for cognition, which are called the neuropsych tests, and I'm used to giving them. They take about 3 to 4 hours, but you know, your mind is made up of so many things. It's what is intelligence? It's your process of judgment, your reasoning, logic, your memory, language, perception, how you perceive things. So it's a big, big, big topic. So when you talk about cognition, it's just not one thing, it's many, it's many things. Research reveals that getting dementia is more fearful now than cancer. I have many people tell me that, you know, I understand cancer, I understand kidney disease, I understand diabetes, but dementia is something that is not. And I recently attended in Europe the World Congress on Alzheimer's disease, and we still don't have a cure. We are nowhere near. We have medications that are pretty dated, which were accidentally discovered. And so, you know, but more and more numbers are getting this.
So difference between dementia, from what I understand, dementia is basically a general term,
So
including
yes, that's exactly what I'm going to talk about. So, okay, let me just first talk about some of the warning signs of cognitive. Okay, so suppose you're working with someone. This could happen in somebody in India, somebody here. So normal aging, as you and I understand it, normal aging will cause some changes. I mean, I could run up and down my stairs 20 years ago. I could do so much. I could drive at night without my glasses. So we all will age. We'll have so many aspects of that. There'll be changes in your speed of thinking. These are all normal changes. Attention, memory, and reaction time. However, this is not part of normal aging. Memory loss, which is short-term memory loss. So I cannot tell you how many, because our families, we are all networked with WhatsApp groups and so many. So I have lots of families, individuals that will reach out and say, Rita, I just came back from India and I noticed my mother, she was repeating herself. She was asking the same question again and again. Or I found that my parents have been living well so far, but suddenly there seems to be some poor planning, some wrong decisions being made. They don't seem to be on top of everything. Some very these kind of things that we hear. Poor judgment, word finding, okay? Confusion with time and place getting lost. Withdrawn from, I'm sorry, I'm missing a word, work and social activities. Changes in mood and personality. Now, if you look at each of these by itself, they don't seem a big deal. But if you put them all together, then that means something is happening. And there is, I've spent 25 years in this disease of cognition and Alzheimer's and other forms of dementia. I find that we are still not very aware. I mean, people don't want to talk about depression. People don't talk about mental illness. So when people have changes in perception or thinking, we are not really either aware of it. We don't know how to act. And typically, like I come from a place in Delhi where I remember 4 years ago, I went back and we had a little meeting about aging. And a lot of the people said, I have a lot of my relatives who are showing some of these behaviors, but we just think it's part of aging. So we just leave them alone. But it's not. Some of dementias can be reversible, some irreversible. So what is dementia? And I think you asked me, sir, a question that dementia is a general term. So think of it as a broad term. And there are literally 25 kinds of dementias. I mean, if I sat here and talked about it, it would take the whole day. There are many, many kinds of dementia. But today, we're talking about just the whole general term. And when you look at the brain after an autopsy, it's a pretty fearful sights. So we talk about plaques and tangles, and I'll come back to that later. Alzheimer's is probably the most common, and it's increasing tremendously now. And one of the reasons, so the others are vascular, which is to do with the blood pressure and small strokes and Parkinson's and so on. I didn't want to go too deep into this. I just wanted to share some thoughts. So if you're interested, you can always ask me for the slides, or if there's anything else I can assist with. There are multiple stages of dementia. You can have, early stage, middle stage, moderate stage, and there's no cure yet, but most of it is managing the environment.
What's Lewy body?
It's another kind of dementia that I can.
So that's somebody's name?
It's a from the professor, from a doctor.
Okay.
Now I just wanted to give you a quick case study. A case study is often like a picture is like 1,000 words. So I had this Indian professor who taught here, has been here since he was 25, and he is a mathematics professor, and his family started noticing all the signs that you and I just talked about. But they did not quite know how to approach him because of our respect for our parents and everything, and they felt that he was losing things more, he was getting a little disoriented, and then finally the straw that sort of broke the camel's back is that the students kind of complained about him and said that he's kind of not keeping on top of his things, and he's getting distracted. A couple of times he's gotten lost, and the family just did not know what to do at that point. So of course, because I knew the family, I did immediately talk about medical assessments. But my point here is that it was such a difficult situation for this family to figure out how to proceed, how to go towards a diagnosis. And then when the diagnosis did happen, he was diagnosed with early Alzheimer's, they did not know how to react, because to them, the father is the professor, he is in charge of that domain. How do you bring him back from teaching his classes? Those classes meant the world to him. That was his reference point. That was his life. How do you deal with the short-term memory loss? So it was a very kind of a heartbreaking situation that we had to go through. What are the causes? It's basically there's a whole lot we can learn about the nerve cells of the brains impacting several areas, memory and higher order thinking. Sometimes we take things so granted, you and I, we can do all of these things so easily. But when you see people who are impacted with this, you realize how difficult some of these can be. One of the things, the research that's coming out is that preventive behavior early on in your life, like in your 20s and 30s and 40s and even 50s, can actually help. I just wanted to show this slide. I know it's not a great thing to look at, but just gives you a perspective of what exactly is going on, because I've had adult children come and tell me, I never had a good relationship with my parents, and my mother is just, fighting me. Her personality has changed. She forgets everything I tell her. Well, then I tell them that this is actually a disease. So this is a person's brain, and you can see that the brain with dementia is how much loss there is in the brain and how different the normal brain is. And all these things we call plaques and tangles that look like spider webs in the brain, and it's one of the most frightening diseases, and we still, most of the time, we don't know the reasons.
So what do you look for in those two pictures on the right in the brain, other than color difference?
So this is actually the way it is a little dramatic to show that this is, if you can see that how much the grooves have happened, like, it's become the darker areas in the brain. That means you've lost a lot of volume in the brain. Okay, so helping families. Now, if you choose to go into this field, if you choose to work with this particular construct, then how do you help families with dementia or any kind of cognition, whether it's your family member, whether it's somebody in society? I would say, first of all, encourage the assessment. Don't just say, oh, this is aging. Many times a vitamin B12 deficiency, or like Anjali said about the hearing loss or something else, you can have some reversible conditions, but typically dementia is not reversible. Then MRI, blood tests, there are all these kind of tests that are available. Learning about the condition is very important, because this is a very important distinction. Most of the times, the family member, if somebody has dementia where it's interfering with their life, they need help with the daily schedule. They need help with the safety proofing and supervision. Linking them with resources are important. And again, these are all available to you as slides if you're interested. I'm happy to help. Offering links. Now, in this country especially, this is a big deal. The other day, we had a really big seminar on how many people, so there are some very sophisticated scans that are coming up. They cost a lot. They will show you some early changes in your brain. And when we asked the audience, this was at the a group of law school and neurosciences and other groups, how many people will actually agree to a diagnosis or a scan? And not one person raised their hand. So that was interesting. And then the other
that makes sense. Because it's really an irreversible condition. So even if you know, what are you going to do about it?
Right. So I think the problem here comes up is that there are also so many, and here I am just here to explain this to you, that there are also some legal ramifications of this diagnosis.
Right.
So for example, if you have a diagnosis of dementia, you cannot sign a durable power of attorney. So, yeah, and I'm sure you have your own lawyers and financial. I mean, I come across this constantly when I'm dealing with families where, driving is a thing. We are mandated to report the driving.
You cannot drive.
But a lot of people
Insurance
still can drive, and insurance, and there are so many other areas. So I'm just kind of, introducing you to some of these areas. And then assisting the family and the caregiver. If you can do that and help them build a plan of care, I mean, that would be the ultimate, kind of a support to them. Helping patients with dementia. I don't know how many of you would like to be, interested in this, but just a patient alone. So now imagine, I'll give an example of this class that I took many, many years ago. Think about how helpless you would be if you had some kind of short-term memory loss. In that case, you would not know who I am, why I'm speaking to you, what will you be doing once you leave this hall? That whole fear of memory, it is absolutely terrifying. And if you try to capture this and think what it feels like for patients with dementia, which is why half the time you see them, becoming paranoid or becoming kind of really agitated, it's because of this absence of a comfort. You and I have memory to help us. And so I have this one particular 92-year-old patient that I work with. I've really come to like her. I've seen her through a very active life to now this dependency. Evenings are really bad for patients. And so in the evening, she'll say, I want to go see my mother. Her mother passed away 30 years ago, 40 years ago. So the only thing that calms her down is for the caregiver to kind of contain her in the moment, give her the dignity. Don't just say your mother died, because that logic is not going to work. But, make her wear a coat and walk out of one room and say, okay, let's go meet your mother. So the way of redirecting that feeling. So these are all these little tips that we have learned over the years, and they help with patients with dementia. So daily structure, exercise is absolutely wonderful. In fact, in the last World Congress, they said they've come up with one magic pill for prevention, which is exercise. Environmental cueing. And again, I'm sorry if I'm using some jargon here, but again, if you're interested, because I don't have the time, I'm happy to talk about this later. Agree and redirect is an important thing, that don't argue with somebody, but agree and kind of refocus their energy so that you're being respectful and you're diverting them to another domain. And safety, therapies, and what we try to do is we create a kind of the same kind of a schedule for them so that they are reliving the past, and actually they do, some of them can do quite well. Before I start on this protecting your brain, which actually applies to every one of you here and every one of us, from the age, however young you are, because today the slogan, at least the one that I really talk about, is that what works for your heart works for your brain. So up till now, it's all about heart, heart, heart. Now what works for your heart works for your brain. So the blood pressure and the exercise and diabetes, all of that is very important. I have included a large number of research findings, the latest ones, at the end of the presentation under appendix. So if you're interested, we can do that. So it's the same things we've learned about: blood pressure, alcohol, stress, diet, sleep, head injury, very important. And I just wanted to take, how much have you got time? Fine, okay. So I just wanted to share a study, a cross-cultural study that I'm part of. And I think you'll find this interesting that even if you have a diagnosis of dementia, what this means. So this particular study that we are doing it with a cohort in Mexico, and then a cohort in the United States and one in India. And what we are doing is we are looking at people, we are comparing people. So people with the same kind of disease, and how do we know that? By the brain scan, by the doctors, by whatever they've gotten. And if you compare the three populations of America, Mexico, and India, think about who is doing quite well and who is not doing so well.
India is probably better doing
Exactly.
population.
You're perfectly right. So for the same disease progression, we are finding that people in the United States are not doing that well. The people in India and Mexico are higher. And can you guess why? So for example, this one.
There is lots of social support, family, and so on.
And I have to tell you this. I mean, I have spent better part of my life in this disease. I have an aunt that recently got, this aunt is somebody I adore. She lives in Lucknow. She was part of my childhood, and she got diagnosed about 5 years ago. I cannot see any pathology in her. She still gets up in the morning. She has a shower. She's still cooking. She takes care of her grandchildren. She still fights with her daughter-in-law. It's that she'll still bargain with the milkman. So those are so important. The social constructs where I have so many patients in Lytton Gardens and Idlewood and all these key senior care facilities, living alone, depressed, nothing to do, and their trajectory is backwards. So keeping that environmental cue going. So we are finding that if you look at the indicators of what we call the lifestyle living, we're finding that people in Mexico and India are doing so much better than my cohort over here. And so this is all important information. I want to.
How big is that group? Just
curiosity. So we are about right now we are about 39 patients. We've lost a few. It's not a.
In 3 places or
no,
each
no,
place?
Each place. India is about 39 patients. Okay. So this is the toolkit I've divided. This I hand out to families. Just keep it if you're working with families or aging. And I'm not going to go into too much because it's kind of a little when you look at an older adult, like how we sit for our SATs and our, a tool list. Yeah, exactly. I'm going to go to the summary. Healthy aging starts with healthy behaviors. The 3 M's to remember: mind, mobility, and money. Okay, you need all 3 to succeed. You need money, financial, because otherwise, how will you get care? How will you do that? And you need mobility. Mobility is very critical. And when I talk about mind, I mean physical and cognitive mind. Now, this is one more thing I want to talk about: cognitive reserve. So there's a huge amount of literature coming out on cognitive reserve. That is, the more you read, and especially after 45 and 50, the more you learn a new language. And there is a thing called neurobics, where they're saying that try to do 2 activities, which is kind of strange, like you eat your cereal, but with your left hand also do some activity, trying to stimulate your brain as much as possible. Yeah. So cognitive reserve becomes a huge issue, that how much, even today, if you start, how much you're putting into your brain. So why is cognitive reserve important? Because they say that people with less cognitive reserves tend to have reserves tend to get dementia earlier. And that means that if you delay it, then chances are that you've delayed it much more into your older age, and that way probably you have lesser years to deal with this. My biggest concern in body is early onset dementias, and we are seeing a lot of them now. A lot of early onset in terms of Parkinson's and others.
What is the age range now? The shift in 60s?
Oh, no.
The shift now, you mentioned that it's early, correct? So what?
The earlier ages, the earlier ages can be as early as 35, 45. It can have very early. Yeah. Early onset is quite. So, and my appendix is here. So I wanted to just take a minute, and I know Jarina talked about Sukham, but Sukham is one of our, I believe, and I'm so excited about it, a Bay Area effort in this community to kind of bring best practices. And I have a lot of the appendix, but I wanted to end on one thing. This is the brain benefits of exercise. You cannot believe how important this is. Even if you start at age 80, they say that it has an impact in terms of lengthens the span, the decision making, multitasking. And I want to end on my my work that I've done at Stanford for so many years. So this is a slide that I have written on. If you just think about this, most of you are here, the wellness, the maximum engagement, chronic disease starts around 35, 40 sometimes. And then this is the area that I have spent most of my time with. When you have startup problems, but you don't agree, you're not proactive, emergency room visits, hospital visits, and then the final areas where our next speaker is going to talk about, where we need to have complex conversations. And I'm going to end with the what is it that really kind of makes me get up in the morning and go to work, is that I find that you can have the medications that you need to take. You can have the best practices that you think you need to do. But family dynamics, how we are with our families, how we engage with ourselves, how we engage with others, our attitudes, they become the biggest challenges. And most of the time, the person that calls me is the adult child, and these family discussions and the meetings and not being able to plan. So to me, half the time the conversations are happening when everything is kind of already fallen apart. And the reason being that adult children find it hard to talk to parents about this because we still perceive them as parents. The role reversal is difficult, and we don't talk, we don't plan, and it ends up having problems in the emergency room, in ICUs where people are scrambling. So I want to end on that note that family discussions are so critical, and especially, I created my advanced directive and I talked to my daughter because I see so much out there. As long as you're healthy and wealthy and everything is wonderful, life is great. Things start to happen, and once you combine aging, vulnerability, isolation, chronic disease, things can be difficult. So keeping healthy mind and healthy body, and thank you.
Thank you very much, Dr. Khattak. We'll have a 15-minute, 20-minute break here. Sharp at 2:15 we'll start the next talk.
Thank you. Walk of life.
No, there's a lot of life. It's not involved in all of it.
Well, that's what a walk of life is. It is walk of life, and different walk of life.
Now it's a competition, right? My last time, given so many, but who does it? I'm a leader or even he or
Still I'm doing an amazing job. I can't believe I'm doing it so far. I'm so grateful, frankly. I'm so lucky I did that. It's so informative. I've been listening to all the
Let us have tea so that all of you can be on time. Yes, sir. We will talk about the process part. When you get plan during the week, sometimes plenty of time. Sunny, right? So I was saying something. You should meet sometime. I've taken a shot at it.
If you tell him to raise the heat a little
This is what we can execute, right?
We can walk.
Sure, yeah, absolutely. We can do two things at one time.
At least we'll miss. Let him have tea. Otherwise, we will be delayed. But I can stay. Excellent. Related to so much being my father and my father-in-law both on right, so 30 years on dialysis, my father, and doing dialysis, very little dialysis at home. I almost became for 9 years did it at home every 3 hours.
Here in this,
Yeah. And so peritoneal dialysis is done at home, right?
no, what you're doing, I know, what I'm saying is.
Absolutely, yeah. So I become. Oh, absolutely. My wife actually almost started it, but we had to go
That's
to
the
US.
biggest question I get every time I go there, that find us trained caregivers that can do all of this and have different levels and also work with children with that needs special training. So there's so much of it. I don't know whether the
Huge. It's growing like anything.
Yeah, For example, the people who are doing your dialysis, what kind of training?
So they get trained by the company back there. Right?
So that's the one.
I became so proficient doing it for 9 years. I can even keep myself. Right? started distributing to other patients. Because usually the gap there is, that's really the multinational. They have a product which is there in the market, they're looking at it from a business standpoint. But who's looking at it from the patient standpoint? It reached a stage where when actually their experts come to my home and see what I'm actually doing, some best practices that I evolved over a period of time. I'm a software guy, but you do it for a very long time, you develop best practices, right? Which are very specific to India. Whether it's different, you have different kind of problems. They never devised that catheter, the swan neck catheter to take care of that specific geography and so on, right? And how would that bandage stick or not stick, and what are the different options? So I figured that out, right? So
that's what is so true. That who knows in and out because you're testing it.
I actually started a company with my nephrologist in Apollo for dialysis. Right? I ran 2 dialysis centers for 4 years.
So are you based now here? Or?
I'm based now. I'm a software guy, but I do my software work.
Are you doing any of this, anything else? Because my goal is
huge opportunity.
See, there are lots of these agencies that have come up who provide these, like body, but they're not trained. They're not trained. They're not trained in how to aging or specific to Parkinson's or dementia or special disease, hygiene, whatever. But I don't know.
So huge opportunity and need is there. Actually, my wife started looking at what she takes care of some elders in our vicinity. I don't know which area of Delhi is now, but I'm
house cuts.
We are in the vicinity. We used to in Perfilia,
Okay, yeah.
right? And then now, in the six that is one, next to Aegis 2. That is where I did my but yeah, a lot of opportunity because in my area there, 95% are elderly.
Yeah, because everybody in the young group has left God.
Yeah.
And they're there by themselves.
In our vicinity, 95% is elderly. They don't.
They're homebound.
And they're homebound and they are doing some small little things.
Which I know a friend of mine yesterday said, and my husband's mom, not able to care for herself, would not have a lot of ability to leave the house. So he's having to fly everything hundreds to kind of take care of it. It's hard.
But then there are some really good
When I saw in India, I saw these all these crime movies and I'm more aware of exactly what's happening. You see these investigations.
Oh,
That's right, yeah.
People are vulnerable, right?
very exposed. Completely.
But on the other hand, I'm a very optimistic person. I believe like so there are lots of my aunts and uncles because I have tons of family who kind of join groups. And like in Mumbai, they've just that whole building. They have walking tours, they go out, and they're all in different places. Playing cards. The children are all away.
No, in my area, there's some. They have set up a group. They're very active.
They're very active.
And they joke and they.
We don't need the children around because they can help each other.
Very.
See, I was going to ask you for fear. Yes, that I didn't know if you check it. Then we can have this.
Would you leave your house and join them? I have this best friend. She can actually talk to you. Moved into exactly the kind of because each
Everything going well?
which raises the standard of I think a lot of people are interested in that because these are the people that have resources that need the social arrangements. Do you know if they have a health component?
So I have embedded links in there. So do you think they're gonna work? Do you have internet or?
I do have it.
So this one, the first one right there. I don't want to play the whole. No, it's not right. If it doesn't, it's okay. There's no. I mean, I can just talk about it.
Okay. Yeah, let me try to connect it to the Wi-Fi again, and then
See if it works. And if it doesn't, that's okay. So then if it doesn't, then we're fine. I actually, don't worry about it. It's okay. We'll just rush through. I'll just talk about those. Yeah.
Comfortably, see 3:15 we start from within 4 to 4:50. We went to also we need to give people time and then we have 5 minutes to pick it off and 5 minutes. Okay. Yeah, so we can talk about
Yeah. So the way it goes.
yeah.
Yeah, I can just talk about it.
how long will it take?
I'll show only 2 minutes or 2 minutes.
Yeah, yeah. Yeah. No, that makes sense. Because he taught my dad for 2 years. Me only for a month. Because I went in 11th class. He taught in 11th and 12th. Right? So I went in 11th class, but I only went till before summer. Because after summer I changed school to teacher. Yeah. So that's why. Yeah. But he's a great teacher. Like, I really love him. Really. Yeah. Yep.
Very dedicated,
Yep.
sincere teacher.
Good teacher.
And
Smart person.
he's not like socially with many people.
Yeah.
But in his
He's a math
subject,
person.
he's
He's
not.
a math. Yeah, I really like him.
Now I was relating my subject also with the student. There is one big designer selling in India. They said, "Sir, I'm sending my daughter to you." I said, "For what? For study." I said, "Why? You are a great designer. You should teach your students." I said, "No, sir, I want you to teach." So, like, tell you.
Yeah, makes sense.
Sometimes when you see that capacity of the teacher,
Yeah. The special ability as a teacher. Yeah. He's a really good teacher.
No. Which one is what? We have to decide.
person here?
Yeah, I'm the youngest scholar.
I see. What do you do?
So I'm a computer engineer at Google.
Oh, okay, nice.
I just got part of this because I was interested in knowing what all of this was about and why Hinduism could be a potential solution to a lot of these things. But yeah, I'm just interested in understanding. I mean, to be honest, I'm here to establish a baseline in neurobiology of all of these things. I think all religions are just systems to make life more efficient or flow state efficient. And I think these are all just different ways of achieving that state. And yeah, at some point, Hindu civilization figured out some patterns. We didn't really understand the mechanism, but we figured out some patterns which were then embodied in these stories, and now come out with in all of this research and diet and all of these things. So yeah, I just want to be part of translating that to my generation. Because I've done. I used to be a really fat kid, but in my attempts to figure out how to lose weight, I did intermittent fasting. Then I figured out how carb cycle works, and essentially realized that we were like completely destroying our insulin response.
Yes.
And I mean, I told that to my sister, who also she was having some autoimmune skin disease. Inflammation went down, and just by restricting, overall calorific intake. And then I did 5-day water fast also, the 5 days without fast, and I could understand how there were correlations in powering your body strictly through ketones, and then just the mental benefits of it, clarity, autophagy kicks in, and all of those things. So I'm just interested in how, fasting, which is part of almost every religion, Navratri, this, that, everyone does it. I want to put all of that in neurobiology, and then just be like, this is why religion flows. It's not like science is right or religion is right. They're both right because they're both trying to describe the same thing.
Yeah, so one thing that's true for Indian Hinduism, which is in my mind not a religion really, but a way of life.
Right.
And so I can see how a lot of wisdom has been obtained without. And sometimes there are explanations, and sometimes there are explanations that I didn't hear about, but then I hear about.
Right. Sometimes there's autocorrelations also, like you want to see it in an explanation. But yeah, just interested in exploring. Your research is obviously really relevant to, like, I think about, in general, taking care of my dad a lot. He's someone who's also part of the classes. Anil, he was sitting at the back. He's like 50 right now, but he does not take care of his diet and exercise as much as I do. So yeah, I'm sure looking at you from a doctor is gonna make more sense than YouTube videos.
I will take the emails of all of you from Mukunji, and I want to be in touch.
I'll take it. Put it. Anjali.
Yeah, the mic is recording.
So we're starting the second half of our session. Hope everybody's had chai and cookies and is all energized and refreshed. Okay. So introducing our next speaker, Dr. Neelu Mehra, who, as I mentioned, is a palliative care physician at Kaiser Redwood City. She'll be talking about planning for the unknowns of your life, advanced healthcare directives importance, and palliative care.
Thank you.
Thank you, Dorina. Thank you all for having us here. We are really excited to be here, and I hope we are helpful. So I come into your lives when there are turbulent times, when Anjali has taken care of you, and Rita has gone through all the processes with you, and then when we are really faced with decisions, we're faced with what to do next, how to have those important conversations that are important that we have been putting away for the longest time. And what is palliative care and what is hospice? I'll go into the details of that so that it's not a fearful term. It's a very new specialty, and a lot of it is get intermixed with, oh my gosh, palliative care is coming. That means I must be not doing well. So getting a little bit of an understanding so we can make sure that our community especially is well informed, because as a physician, I see a lot of my own folks coming through who have no understanding, they're very fearful, and hence do not get the care that they need, and which is really important at that phase in their life.
What's the definition of the word palliative?
And I'm going to get to that. So I have a whole talk on it. So yeah. So first talk is on how to have these important conversations when you are facing unknowns in your life. What is important and how do we,
That's sensitive.
Yeah, it is. Thank you. So, we plan for all walks of life. We planned when we came to this country, we planned to move here, we had our children, we saved for their education fund, and we put finances into our career, into our life, and we plan for retirement. We do planning. This is what we do this time we were born. Old age should not be any different. In fact, old age should not be the only time when we plan. We should plan right when we subject ourselves to any kind of danger out there, which is 18 years and above. 18 years, we're very excited to go get a license, but we never plan on that we could be hit on the road. Then what? So these conversations are important right from the time when you take or assume responsibility and you have decisions that you're faced with. So creating healthy habits, eating good food, like we talked about, doing plenty of exercise is all important part of our age. It is a legacy.
Somehow everybody seems to imply that it's important only in during old age or whatever it's supposed to be. It seems to me that everything you have written here applies to all ages, from birth to death.
That's what she just said.
That's what I just said. I just said that it shouldn't only be old age. It implies to everybody 18 and above. The minute you're out there, you're responsible, you're subjected to any kind of uncertainties in your life, is when the planning should begin.
Yeah.
Right? Because before that, parents are planning for you. After 18, you're out there in the world, your parents may not be with you. So you have to make sure that you are informed and educated and you're able to make your decisions. It's a legacy you pass on to your kids. If you make important and good decisions, that's what your kids learn from you. Whether it's your estate, whether it's your wisdom, whether your values, your wishes for your care, those things have to be talked about, and your family, your kids, and you should be very clear about what you want and what you don't want. Because life has no biases. It doesn't look for old age. It doesn't look for young age. It can throw you curveballs at any age that you're at. So it's important to be prepared and to be ready, right? So Paul Kalnicky, I don't know how many of you know about him. Have you heard of him? So he was an aspiring neurosurgeon who was actually training at Stanford. He wrote a book before he died, which is called When Breath Becomes Air.
He was 40 years, early 40 years.
He was 40. He was aspiring. He was going on for his dreams. He was going to be a neurosurgeon. He had a young family. He was forward going until he got diagnosed with lung cancer, which was metastatic. Life came to a halt. He had not planned for this. His aspirations for his goals of life were stagnant. They were the perennial present of what he was faced with. And his wife and him had to plan, had to figure out what they're going to do, what the next step in their life is going to look like. Lucy Kalniti, his wife, who was also an internist, who is an internist actually at Stanford, stood by him every decision that he made. They made decisions together. And she said taking care of Paul at that time was some of the best times that she had and some of the worst. So it comes with a lot of emotion. It comes with a lot of baggage because it's not easy to see your loved one going through what they're going through, but yet important decisions have to be made. They planned to have a baby while he was not doing well. He planned to continue on with his residency and actually finish it. He could not go through the commencement, but he actually finished it even though it was hard. He had neuropathy or numbness in his fingers from chemotherapy that he was having. He managed to write that book. So these are the decisions that they were faced with on a day-to-day life. There were moments when they felt, he said, I can't do this anymore. Lucy was there by his side. They decided things, they followed it, but what was important was the conversation that they had actually helped him through his life moving forward. So she says that, don't hide from suffering. Suffering is a normal part of life. When you were born with an expiration. You will die one day. So that doesn't mean that you live in fear. Oh my gosh, I'm going to die. But then you prepare for it and then put it away. And then you focus on living is what's important. So she said it provides greatest opportunity to love and be loved. Because that's how you show that I know you as my partner. I know you as my parent, or I know you as my child. And I will do and help you get or accomplish what you really want. So it's about knowing them well. Always be ready is what's important. Randy Pausch, I don't know how many of you know about him. So a few of you. So he was a professor at Carnegie Mellon. I have these embedded YouTube that you guys can watch if you have time. I know the links are not working, so we'll just skip those. He was called to come.
Working.
Oh, they are?
If you want to watch, internet is there.
We can try. If it doesn't work, then
Yeah. Well, he was a professor at Carnegie Mellon, and Carnegie Mellon has this ritual that they invite their professors at the commencement, and they call that commencement the last lecture. So what that means is they say, give this lecture as if it was the last lecture of your life, and what advice would you have for the young aspiring people who are graduating today? It's okay, don't worry about it. So he was called to give that last lecture. They did not know that he actually had pancreatic cancer. He was diagnosed with pancreatic cancer, and he was actually battling. He had a decision to make. Should he go? Should he prepare for this? Should he go around travel? Or should he spend time with his 3 young kids? He wasn't planning for this. He was the healthiest guy you would ever know. He wasn't doing any of what Anjali talked about. He didn't smoke, he didn't drink, he exercised, he did everything right, yet life came in the way. So he came in, and if you watch it, it gives me goosebumps every time I watch this video. He actually did exercise on the stage. He said, I'm healthier than most of you sitting here, and yet I'm facing this finality in my life. I have 3 little kids, but I'm choosing to spend the time that I have to create legacy for my kids, to write this book, to give this lecture. And we did it he involved his wife. They decided what's more important, and he decided that leaving a legacy for his kids was more important, even though it meant taking time away at that point in time. So he wasn't planning on this. It just fell on him. He had to face it.
You said something I didn't quite catch. You said it was more important for him to spend, to create a legacy.
Yes.
Than doing what?
Then being present with his kids at that point. This involved traveling. What he did in the next 6 to 8 months, so which meant staying away from his kids. And some of them could be fearful, and they would say, well, I'm not going anywhere. I'm not going to do anything. I'm going to just spend the rest of my time with the kids. But he focused on creating a legacy for them by writing a book, going for that lecture. And actually, he went around and created a lot of charity and a lot of lectures that he gave.
Actually.
That's right. Yes. He died in 2008. We're standing here in 2018 still talking about him. And his kids are probably growing up. They were like 1, 3, and 5 at that time. Right? So he wasn't planning on this, but it did happen. So whether you choose to talk about it or not, things will happen. The only difference would be that you would not be prepared. Oh, something happened. Oh, Sheryl Sandberg. I guess we all know about her, right? She's a CEO, went for a 50th birthday party for a friend and finds her husband dead in the gym. Who was CEO of SurveyMonkey at that point? They had 2 young kids. She flew back with her dead husband to tell her children that their dad was no more. This was not what she had planned for. This is not why she flew to Mexico. She was going there to party, not to bring her dead husband back. But things happen to all people, young or old. These are young people, I'm giving you examples. Old age, you may still be prepared. You may still be worried about your that I may die at some point or I'm getting closer to the finish line. But things happen to younger people too. So always be prepared is the key message here. It is how you choose to express yourself is what's important. Life will bring you uncertainties. It'll throw curveballs at you. How you face it, are you prepared for it, is what is important. And how you enjoy your life. Live every day to the fullest. People say, live every day as if it's your last day on this planet. What boils down to your bucket list is what you should focus on. Because we run the mill of life. We're like running here, running there, and doing things and not finding time for ourselves. Not finding time to talk to our loved ones, to tell them what is important to me. If I'm not there tomorrow, what do I want to leave for you? What legacy, what lesson, what knowledge do I want to leave for you that would be important? And that'll help me live through you. Like Lucy said, Lucy Kalniti, who was Paul's wife, they did an advanced directive together. She said, it was an act of love. It was a pact to take care of each other. It was a promise that they made to each other that this is what I will do, planning for our future, which is mystical, but is inevitable. Each one of us has to go one day. Whether you talk about it or not, whether you plan for it or not, it's going to happen. So how should you plan? This is not a dinner table conversation that we get to have every day. Okay, let me talk about my death today. It doesn't happen that way, right? But yet things happen. You have to make time. You have to feel that these are normal conversations that you have to have. And these are equally important, just like as you plan your life insurance, just like you plan your retirement, just like you put your 529 for your kids' college funds. And this is equally important, just like any other planning that you do in your life. Is it easy to talk? Not really. I mean, this is the most uncomfortable topic. That we, in the United States, we are very vocal about a lot of things, but the one thing that we are very uncomfortable about is death. We think it's never going to come. It's going to happen to my neighbor. It's not going to come to me, right? Anything bad will happen to somebody I know, but I will not be in their shoes, right? So invincibility, we talked about that. We think we're invincible. Nothing bad is ever going to happen to us. But it takes one event to pivot. I had a friend who was diagnosed with cancer, and we were in a group setting. We were talking about, the question was, if you were asked to live a day that you would ask to live again, which day would that be? And she said, the day I didn't know that I had cancer. The diagnosis of cancer pivoted her life to different discourse, a different path altogether. So until it's going well, it's great, but when it goes bad, it hits really hard and we're not prepared most of the time. So the challenges are, it'll happen to us if we talk about it. Why talk about bad things? Because if you do, it'll bring us bad karma and it'll happen to us. No, it'll happen even if you thought it will not, right? Because it'll happen at a time and you will not be prepared whether it's going to be the only difference. I'm uncomfortable. A lot of patients' kids come to us and say, I know, I recognize my parents are declining or my parents are not doing well, but I just don't know how to talk to them about it. I'm uncomfortable bringing up these discussions. So as parents, it's our responsibilities to break those barriers and say, this is what I would want. If I'm not able to do X, Y, and Z, life is not meaningful for me. Or it's okay if this happened, I could live with this. So where's the line in the sand for you if you don't say? People would not know. They would be left guessing. And that's the worst thing you could do to your loved ones or to your children. So why talk? I mean, why is it so important to talk about these things? What if we don't talk and we just keep living, and whenever things happen, it'll happen and we'll deal with it, just like anything, any other crisis in life. So the biggest emotion that people are left with, the person who is dying is going to go away. That's done. But people who are left behind, they're left with a lot of regret, a lot of doubt. I wish I could have done something different. Maybe things would have been different then. I wish when she called me, I could have taken her to the doctor and things would not have gone bad just the way they did. So we blame ourselves because we never had those discussions. Our physicians are uncomfortable having those discussions. We don't want to disrupt the hope that you're hanging on. So hence, nobody talks. And things keep going along. And then in the end, what's left is regret of not mending the relationships, not saying, I care about you. I love you. I'm sorry for what I did to you. Those words are left unspoken and unsaid, and that's the regret that we're left with. There's no complete, or there's no you don't get the closure, if you will. Yeah, and then you're left with thoughts that can haunt you for the longest time. Leaving family members with unanswered questions and regrets. That's the biggest thing that you'll be left with. So how do we talk about this? A lot of people have come up with very creative ideas and say, okay, how do I know what is important to me? What does quality of life means to me? And it could be different for different people. For you, quality of life, maybe I could be in a wheelchair and I could live just fine. For me, it could be, no, if I cannot walk or I cannot talk, life is not meaningful for me. I had a patient who came and told me, I can live on life support for 20 years, no problem, right? And there are patients who come in and say, no, I don't even want to go that route. Because if you're going to subject me to machines, if tubes is all I'm going to have, I'm not going to be able to live that way. So it's a very personal choice, and only you can tell your loved ones what that choice means to you and what that looks like to you. Because it's not fair for them to make decisions on your behalf, not knowing what you would have wanted in the first place. So Stanford came up with a project they called Dear Doctor Letter, or it's called the Letter Project. So what it talks about is, what's important to me? What does a good day look like in my life? What do I enjoy doing? And what do I remember the most? What memories are most meaningful for me? And what do I want if time was running short? If I'm diagnosed with a life-limiting illness or a progressive illness, what boils up to my bucket list? And what would be those 2 or 3 things that I would absolutely want to do? And how should I live the rest of my life? And what should be important to me? And this letter is sent to their doctor, so their doctors, but then more importantly, you have to let your loved ones know that this is what you're talking about, right? This is what is being, I have had so many patients who come and they say, I don't want life support. And then there comes the daughter and who says, no. I want everything done to my mom. Because the mom told us, never told the daughter that this is what the decision I'm making. And then it's suffering and trauma for the person who never wanted any of it in the first place. So it's not just important to know what you might want in your mind, it's important to communicate to your loved ones. And that's why having these conversations are very important. So this letter actually is a very good format, and you can download it off on the internet, and it guides you through all the questions that forces you to think. Kaiser has an advanced directive that gives you these questions, which forces you to think and pencil down and say, what is a good day like? For me, the good day may be working in my garden. If I'm not able to work in my garden, maybe life is not as meaningful for me as it would be otherwise. So I had a family member who, her husband died and died really poorly. He had lung cancer and did not make these decisions, did not make these choices. and they had to decide everything for him. So he died in the ICU on the ventilator. It was a very traumatic experience for the family. So the wife said, not me. I'm not going to do this ever to my children again. I'm going to make my advance directives, make it clear that I don't want to be in life support. But what she did not plan for was that along the way, so there's life and you're living and you're dying. There's a path in between. When you're really living with burdensome illness, which brings you symptoms, which brings you lack of resources, financial instability, and not knowing, not talking about each of these issues with your loved ones can actually subject you to a lot of trauma and a lot of hardship. So it's important not just, and we'll talk more about when I get to my next lecture, but this letter project, if you have a chance, you should look at it. And then Go Wish Cards. Go Wish Cards is a game that you play with your family members. And again, it says, what's important to me? Is it important for me to be home when I'm dying? Or is it okay for me to be in a nursing home? And that is a very pivotal question. Because as a family member, if you never told me, and if you assume that I'm going to have you at home, and if I'm a working daughter, I have 3 kids to take care of, I'm financially not that stable, I cannot hire caregivers to bring them home, what am I going to do? I may not have too many choices, but to consider sending you to a nursing home. So telling that daughter that maybe it would be okay for me to be in a setting if you were not able to take care of me is actually very important for her to hear, for her to not be left with regret at the end of our life. So quality versus quantity is a choice that everybody has to make towards the end of their life. Do I want more time or do I want better quality? And if I want more time, then what is the cost I'm willing to pay? Is it okay if I was in wheelchair? Is it okay if I was cognitively not there? Is it okay if I couldn't talk, but I could understand and process? Those are the things that you have to break down, which the advanced directives help you do to define what's meaningful for you. If the time was running short, what would be important for you? And that gives a guide map or a road map for your family members to make decisions on your behalf. And that also includes dementia. In dementia, very early on, you may lose the ability to even make decisions. I've had patients who have spent their entire money because they still insist on balancing their checkbooks and without telling their loved ones that they're actually not able to do it. And they have donated their money to charities and they have gone bankrupt just because they wouldn't talk to their family members. So it is a gift that you leave for your family. You tell them what is important. If your health takes an undesired turn, what will be your most important goal? And what are your biggest fears and worries that you would want them to know so they can keep that in mind and provide the best care that they can for you. So United States, the healthcare is very challenging. It's not like back in India where the doctors will say, sorry, we can't do anything, take your loved one home. We don't do that. We always give you choices. Do you want to be on life support or do you want to go home? If you want to be in life support, you know the end would be still the same. The difference would be that you'll die on machine versus you'll die at home, surrounded with your loved ones and where you want to be, right? So navigating your treatment choices in the United States is very important, and it's important to know what you want, what your choices are, and interrogating your physicians who are very reluctant to tell you. They may be talking amongst each other, and I can testify to that, but they will not tell you that going on life support, meaning you're prolonging your death. We're not giving you any meaningful existence at this point. So you have to be your best advocate. And for that, you have to understand and you have to know what your choices are. Learn, read, and understand, make informed choices, know and understand your choices well, ask questions, make sure you're understanding the treatment that you're getting is what you really truly want. So this is the end of my first talk. So that segues into palliative care and hospice. I think that's in a separate folder, I think. Just click it? Oh, awesome. So when the going gets tough. So the objectives of this talk is what is palliative care? What are the differences between palliative care and hospice? Because oftentimes palliative care gets confused with hospice care. And we are not utilizing these specialties to their maximum abilities. And because we are so fearful that palliative care comes and talks to me, that means death is facing me and I don't want to talk about it. And if they don't come, as if it's going to go away. That does not happen, believe me. When should we involve palliative care and when should we involve hospice? So 75% of the Americans in US would want to be at home at the end of their life. But 80% actually die in the hospital. And that is a huge disconnect. So what they're saying, what they want is very different from what they're getting. So where are we failing? So there was a trial that they did, 9,000 seriously ill patients. 50% of the patients were conscious. They were aware of the surroundings at the end of their life, but they experienced moderate to severe pain. Their symptoms are not well managed. The physicians are very good at treating life. They're not good at treating when you're failing. And they're very poor at recognizing that you're failing. And that's when you have more suffering and things do not go the way you plan them to be. The DNR orders, which is like, I don't want to be on life support, 46% of them were written 2 days prior to death, when these conversations should have been had years ago. And then only 47% of the physicians even knew that you did not want to be on life support. There are so many patients who come to the ED who have their preferences known and they get intubated and in the ICU and they die a miserable death because this was not communicated. So that brings me to my first point, having those conversations. So where is the system failing? And I know the earlier speakers talked about our technology is so advanced. We're so cutting edge. We can bring dead people alive. We can dialyze. We can give you that next intervention that we have created or we have made for you. That'll sustain you, will help you breathe, but may not help you achieve what your goal is, which is to live a meaningful existence or a meaningful life. Maybe sometimes we think we're invincible. This will happen to the next door neighbor, not me. And our discomfort in having these conversations is the bottom line. We're not comfortable having these talks. And that's what fails the system mostly. Physicians are reluctant. Like I mentioned earlier, they will not tell you that your prognosis, the predictions that they make are actually, they overestimate by a factor of 7. So if you have 7 days to live, they will tell you have 7 weeks to live. And that's not because they are not aware. This is a guesstimate. This is not an exact science. So I will tell you, but I don't know. So we'll talk about why that is. So one is that we are prognostically uncertain. Prognostic is like how much time do you have in a given certain illness? How much time do you have left? We just don't know because we don't have a direct line to God. We don't have a crystal ball. So we cannot tell you when exactly you're going to die. So we say we hedge on a positive realm. We say, well, it could be a few months when it could be days. And then the other is they don't want to be perceived as giving up on you. When you come in, my loved one is going to fight this battle of cancer. We will win this battle. So that's great that you're bringing so much of enthusiasm, but cancer was never a fight. It was never a battle. It's a journey. You have to go through the ups and downs. You have to move through the path and accept what comes. And above all, prepare. They say, plan for the worst and hope for the best. When you have a fire extinguisher in your home, you never plan your house to go on fire. You have it as a safety net. And that's what it's all about.
Is it the revenue, whole institutional consideration, there is a business aspect to that also, right?
So our Medicare dollars, 80% of the Medicare dollars go towards last month of our life.
That's correct.
We're getting bankrupt very quickly in our health system. So again, this has nothing to do with the specialty. It's a lot to do with how uncomfortable we are acknowledging our own mortality, right? We never came that we will live for 120, 140, 150 years. We will die. We're mortal beings. We're called mortal beings for a reason.
It's a cultural factor too, I guess, depending on the society. Basically, hey, we are not gonna give up.
Yes.
We are so advanced. we can do anything.
You know,
And
there's-
that's why we spend so much money in the last month or two,
that's right.
because that's a cultural factor.
It is. And it's very, very curious that I see all different cultures play out in a different way. Our culture is no different. US, they come with, we're going to fight this. We're going to just get through this. Our culture comes in with that uncertainty. What you're telling me is actually true? Or you're hiding something from me that I don't know? And you could give me the next best thing that you're not telling me about. So either way you look at it, Chinese, different spin. Other culture. So every culture brings a unique flavor to this specialty, and that's what is fun about this. But above all, the important thing is we're very uncomfortable with this topic in general.
Discomfort is one thing, but I think the idea that, hey, I can overcome anything.
Yeah.
You know, not acknowledging the mortality in the first place.
Yeah,
That's, I
yeah,
think,
absolutely.
because, you know, if you say, hey, I can overcome it, what's the problem? I have lots of money.
Completely, the basic human spirit, like of hope, always plays a big role. Right? It's not being there to prove something, but it's very difficult to let a loved one go like that. Right? So you put your best foot forward.
I think we should have this
discussion after the class.
Okay.
It's the person himself that's doing this. For the most part, the person who is, I assume that what you have written here refers to the person who is going to live or die depending on something that's happening to him. He may be sick, she may be sick, and the doctor may say, well, you will last 25 days, and then it may turn out to be 3 days, as you said.
That's right. That's the biggest problem.
Yeah. Apart from
prognostic uncertainty.
so, you know, the person doesn't know. If the doctor says you are willing, you can live for 25 days without pain and whatnot, then he will obviously choose the.
So these are good points. I think we'll bring up in the Q&A session. We'll have a good discussion there. Maybe should we do that?
Yeah.
Sure.
Yeah.
Okay. So, but the reality here is that being honest about the prognosis or saying that, you know, I fear that this might happen actually causes less depression and does not take away hope. So there have been studies that have been done on it. In fact, failure to provide exact information can lead to unnecessary pain and suffering. And that's a discussion we'll have, and there are important points that I'll make there. But the consequences there are the treatment plan does not focus on alleviating your symptoms. We're focused on getting you the next best thing that could be available and get you to the next point in your life, but it never happens. You keep going, declining, the story of decline keeps going on. And then urgently we call for palliative care, then palliative care should have been involved very early on in the gamut. Then we say we offer them, do you want aggressive, do you want to go on life support, do you want aggressive care, or should I call palliative care to talk to you about this? Because palliative care brings one element that palliative care brings about gazillion other that I'll talk about is ability to communicate. So we utilize only the communication ability at that point in time and not what else they bring to the table. So what is palliative care anyways? So it is an interdisciplinary team. It has a social worker, a physician, a chaplain, and a nurse. So they all come together, and the reason that they're there is you have various issues that you face when you're facing a challenging illness. You may be financially not secure. Your social situation, you may not have a caregiver at home. You may be having pain and symptom issues that are not addressed. So I'll talk about a case study that I'll go more in detail with. But the truth is that palliative care actually prolongs life. There was a study that was done on lung cancer patients. One group had palliative care intervention, the other group didn't. The one with the intervention actually lived 3 months longer. So not having palliative care is probably lack of knowledge on our part and the lack of knowledge on physicians' part, and then acceptance of this new specialty, which can actually make your life really, really meaningful and better. It should be initiated as soon as you're diagnosed with any kind of illness, whether it's cancer, whether it's heart failure, whether it's lung disease, whether it's dementia. So as soon as you're diagnosed is where the specialty should come in and help you navigate the healthcare system. You can pursue aggressive care while having palliative care. It should not be a choice given to you. You should be asking. It's a consultative service. So you don't get it automatically. You have to ask your doctors, I want palliative care involved in my care. They may give you a pushback sometimes. Some people, not everybody's aware and knowledgeable about this. They say, well, why do you need palliative? You're not dying right now. You said, no, that's not just for dying people. So, so this is where it is when you get diagnosed with the life-limiting disease, whether it's diabetes, whether it's hypertension, chronic kidney failure. This is the trajectory that it takes. You go, you have all these curative treatments, and then when you have 6 months or less left, is when a determination is made that you could qualify for hospice, and I'll talk about that in a minute. And then, when you are going through these curative treatments, the burden of symptoms keeps on going up, and the options of curative treatments are narrowing up for you. There's a gap that's coming up. And then, palliative care is helpful throughout your symptom trajectory. And when we get called is right around here. What we do is we are conduit to transfer you over to hospice. We're not really doing anything that we can do to make your life better or to help you tolerate these treatments actually better, especially in cancer. Because a lot of symptom management, a lot of side effects that you get from chemotherapies can be managed much better if you have palliative care involved. So we'll talk about Frank. Frank is 58 years old. He came into the emergency room with cough and fever, and he was admitted, and he was diagnosed with metastatic lung cancer. This is not something that he planned for. He was in excruciating amount of pain. He needed radiation for his cancer treatment, but had no insurance and no money. He separated from his wife. His social support was very poor. He used to live alone. His kids were there, but he was not very engaged with them. He had some family out in the Hawaiian island, but nobody was really, because he could do it all by himself. The palliative care was called. This was one of our facility is a little bit upstream with palliative care. They do involve us when they get diagnosed and when they have pain and symptom management. So our team was called. So we figured out pretty quickly the pain was not just physical. He had spiritual, he had emotional pain along with that. And the emotional pain was, what am I going to do? I have this illness. I can't even make it to my radiation treatments. I have nobody to take me. I have no social support. How am I going to get there? So what palliative care did, they applied for state insurance, which is called Medi-Cal. If you make below a certain amount, you qualify for that. You can get in-home supportive care through that, which means you can get caregivers. It's a long process. That's why planning is very important, and getting palliative care involved is very important. So his transport was arranged for. He got his radiation treatments. We provided, our chaplain went in and provided spiritual support, connected him with his family, and he actually was feeling so much better that he felt he was on top of the world. And he called us and he said he wants to make a trip to his island. He wants to go to Hawaii to meet with his family, given that he has this disease and anything could happen anytime. So our team actually, so this is a small island. The hospital was in a different island, and there was a little clinic. So we actually called out to that clinic, made arrangements, gave his medication, gave him enough so he could last him that long for his pain and for his dyspnea, shortness of breath. And he actually did really well. And he went there, he stayed for a few months and came back, and he did really, really well with his symptoms. And he continued to live for almost a year and a half, actually, since the time palliative care got involved. And he utilized some of the therapies for cancer. He tolerated them really well because he managed his symptoms from the side effects. And then one day we get a call from him. And this is where I'm going to talk about the prognostic uncertainty, that even the best people, even palliative care physicians, can overestimate prognosis by a factor of 3, which means if you have 3 weeks, if you have 3 days to live, we tell you you have 3 weeks to live, right? And that's how the nature of the medicine is. There's no right or wrong answer there. He calls in and he says he is in excruciating amount of pain, and he was breathing really heavily. We thought he have only 2 or 3 days left to live. We went in there, we managed his pain, and 48 hours later, he calls us and says, I'm going to go to Philadelphia to attend my son's wedding. So he attended the wedding. Hospice got involved at this point in his life. He attended the wedding. He saw even his grandbaby being born. And he died peacefully surrounded by his family. And hospice was there to help him. And he lived even on hospice for 8 to 9 months. So what is hospice? That brings us to the point. Hospice is supposed to be where you go and you have a drip running and morphine is given to you and you just die. And that's because we refer you guys so late in the game that there's nothing else for hospice left to do but to give you medications to make you comfortable. So when you get hospices, when your life expectancy, if two physicians think that you have 6 months or less to live, and I already talked about how bad we are at prognosticating. So some people live a lot longer. I've had patients with lung cancer who lived a year after giving up their chemotherapy. And they lived really, really well. In fact, this patient of mine, she would call me, "Are you really sure I have cancer? I feel great," right? So this is the power of hospice because they get involved so late that you don't utilize them to their maximum potential. And it's a covered benefit. Medicare covers it. They will not cover, so they're not there 24/7 in your home. They're available 24/7 if there was a crisis or something was happening, you had pain, you have symptom management issue, they can come into your houses even in the middle of the night. But they will not provide caregiving. So if there were physical care that was needed in the home, that's the family's responsibility. But they do have a health aide who comes and showers and bathes the person. They have a volunteer. They have a social worker. They have a chaplain. And they have also bereavement support that they provide for 13 months after the loved ones pass away. It can be offered anywhere. It's a philosophy of care. It can be at home. It could be at nursing home, at assisted living, whichever place you call home, they will come to you. And there's also inpatient hospice homes in the community that patients can be sent to. But again, the cost is not covered for boarding and lodging. You qualify for those facilities if you have acute symptom issue or you have life expectancy of 2 weeks or less. So those are but there are, if the symptoms were not managed at home, there is a possibility to hook up to these inpatient hospice facilities in the community. Mission Hospice has one. There's one in San Francisco, and there are a few others around the area that can be taken advantage of. So the focus basically is quality of life. And again, I already talked about this. It's a philosophy of care. In fact, patients tend to live 3 weeks longer on hospice versus without, even if they have cancer. So a lot of my patients, they actually graduate from hospice. The way it works, once you qualify, you have 90-day period that you get enrolled in hospice. At the 90-day mark, the hospice doctor will come in or the nurses will come in and see, are you still declining? Is there still, your health is still deteriorating? Because heart failure patients and lung patients, they do so well with hospice, they often, even dementia, they graduate from hospice. And as soon as they graduate, they start declining again. I had an older couple, the wife had dementia, and so I had gotten hospice in. She graduated, she did so well, and he hounded me every day to get hospice back in because he had so much support. I had to go in and do a home visit, and I was able to qualify her. She lived in hospice for actually more than 2 years, off and on. So that's the power of hospice. The hospice should not be when you're dying, and there's nothing else we could do. So common priorities for hospice is, of course, it enables you spending quality time with your family and friends, meaningful time. You can die at home, maintaining your dignity, your self-respect, managing the symptoms, and allowing a natural and a peaceful death at the end when it's time. It doesn't expedite anything. It doesn't prolong anything. Like we have the notion. Okay. It is underutilized. The national average, the number of days that people live in hospice is 6 days, whereas 6 months is the qualifying criteria. And most people could live for a year or 2 years, especially the dementia, heart failure, and the lung patients. So it is time to self-advocate, know your options, what your options are, and guide your own care and educate, most importantly, to get these ideas or notions that are ill-founded, that people are not accepting these wonderful services because they have this notion, oh my gosh, if I accept it, that means it's the end road for me. So that's it.
Very depressing.
Very
useful.
Very informative.
That's right. Yes.
Very concentrated.
I don't know how you're doing your job, but very depressing.
It's very meaningful. I mean, life is good and bad, up and down.
Right. Keeping your energy and talking these things is not easy.
Yeah.
Yeah.
It's a specialty much underutilized. I think so. If what we can take away from Dr. Mehra's wonderful talk is write your advanced healthcare directive, persuade your family and friends to write their directive so you can take charge of your own care.
That's right.
And then understand what palliative care is. So any major illness that you have, ask for it. And hospice is a free benefit.
Yeah.
A good amount. We're not utilizing it. Utilize it. Let's not fear
And
it.
palliative care is covered.
And so we'll have a Q&A session. We'll have all our speakers. In addition, we'll have Dr. Jyoti Lulla.
Doctor.
Your Q&A.
Our panel is available.
And, for all the 3 sessions, please feel free to ask questions, discussion. This is our time.
I think we have to shut it off.
I can share it off. Recording. Can I put the lights on? Please.
Yeah,
Lights are on. Yeah.
Please do. Well, I think I'd like to start with a comment and then one personal experience from my own life. The comment is that I think among the medical specialties, palliative care in this area, are the most enlightened. I mean, just like you're saying, how do you deal with it? And actually, I have people with they have a different mindset. How you look at life, how you look at people, and that extra. You have something extra. That's what keeps you going every day and with a high energy and determination to help people. So that I think is very, very commendable. And that applies to all of your this practice towards older people. But in terms of my own life experience is that when I lost my spouse 40 years, some years ago, and read another about that. And I think the lesson that I learned, and I sort of made a little video for the community also, I call that the first death planning. The fundamental thing that we don't deal with as human beings when you get married, and that just like when you're born, you're going to die. When you're married, it's very clear that one of you is going to go first.
Ahead of the other.
Ahead of the other. And you don't know who that is going to be.
No.
So I think that what I learned was that I think the most enlightened discussion that you can have in a family between a wife and husband, spouse, and whatever we would call the relationships, is to say, by the way, that is going to happen. What are we going to do? And that applies to both. It's very symmetrical. It is not man, woman, whatever. It is symmetrically. It has to do with the directives. It has to do with your assets. It has to do with your children. It has to do with your wishes and all that stuff. And so I was very fortunate. I was able to do that a few years before my wife passed away. But that is one way I think become more understandable in that first death context. And then once you do that, then second that follows. So that's just sort of one comment I wanted to add, because I sort of lived through that and talked about it.
Thank you. That's really meaningful. I mean, I have my personal experience, and you say how you do these things. My mom passed away when I was 13, and she was diagnosed, and we went from one doctor to the other, to the other, to the other, and everyone would say, oh, she has this, no, the other one has it. But what she died of the complication from the medication. So if palliative care was existing at that time, because that's the first thing we look at, what medication is doing what. But Rita said, most of the elderly folks, they come in with polypharmacy. So that's the first thing we look at, which medication is causing what side effect, so that you are not escaping anything, or you do better with less, is what the deal is. So that's very gratifying. It's a payback that, nobody should ever die because they were not supposed to. right? And medicine is very tangible. You can make mistakes, things can happen, right? So this is it's a layer of support that comes in that can make sure that it looks at a global picture, talks to you, makes things real and tangible, and make sure that you do well. And given that you're already faced with the illness that you have.
I think, and just to add a little bit to what Kailashi said about talking to a spouse, I think that's very extremely important, because I'm sure Dr. Mehra will agree with this, that when spouses are asked that, what do you think your wife end of life care, what do you think she would want or he would want? 80% of the time, what they are saying is not correct. So what individual you think you know your husband and wife, but really your end of life care wishes, what it is that is meaningful for you at the end of life. Somebody may say that, I want to hear this chanting, that is important to me. Somebody may say, I need someone to hold my hand, that is important to me. So this is one game that we have, a Go Wish card that you manage. Actually, Sukham has a whole deck of them. We have a very large deck of Go Wish cards that we do have, and we do play with, this way that pulls it out. So those conversations with spouses and families are extremely important. Yes,
If I may just add a comment to that. I think, Neelu, you said that, Lucy Kalanithy said it was an act of love to do the advance directive and also to then share it with the family so people know. I know of a case where the mother came from India to visit her daughter and son-in-law, and when she was here, she fell ill and went into coma and was in the hospital. Her son in India flew over, and then the son and the daughter had two opposing points of view as to what they should do about their mother's life. The mother never knew anything about this because she was unconscious, but it tore the family apart because the son and daughter, it became extremely unpleasant.
Very common.
So,
And I see that more commonly than you think.
Very common.
and so it's not that just that you are doing it for yourself. It's you are doing it to keep your family intact. Yes, by telling them, if both of them knew this is what my mother wanted, this is what my mother did not want.
They make it much easier.
May I ask, what is the process for sort of writing out the advanced health planning?
The process is very simple, and we actually give workshops on that. It's a 4 or 5 page form that has to be filled. It takes you 10 minutes to fill it out. The process of filling the form is the least important part of it. Everything that Neelu talked about in her having the conversation, defining what you want for yourself, filling it out, sharing it with people. That's
But you can download the form online too.
Yeah. And if there is interest, and I will make this offer for Sukham, if there is an interest in this course on learning how to have the conversation in more detail and fill out an advanced healthcare directive, we can do it.
That's
We will do a session.
We can do a took words out of my mouth.
Yeah, we should write it, and you should prep us to have
So
those.
Dr. Lula wants to say,
That's exactly my part, which is supposed to be the
No,
end of the
it's
session.
wonderful.
I have brought the advanced healthcare
Oh, great.
directives and to go with actual hands-on to the symbolism, understand that these people need, but I don't have a time commitment.
so in the
So I
end,
have
if you want to talk about.
So I brought the exact directives with me and we go through what are the problems in filling out the form. So it's a hands-on thing. So coming back to the scenarios, recently in Kaiser Hospital, the person had written his directives, had said that he did not want to have this care of being on a ventilator and all that. In spite of those directives, when the person was in the ICU, the doctor demanded extensive care. For 6 months, we had to keep the patient in the ICU because my daughter would not let us put on because she forced the physicians in spite of the patient having written the advance. So there are sometimes these kind of scenarios too. In spite of the, they need to honor, then we have to have
A post form is what he sign, which is a physician's order of life-sustaining treatment. I agree with Mukund, that it could be a separate session. We can tell you
Yeah.
what paperworks are existing and what are important and what phase of
We can
the
coach
disease
you through
process.
the whole process.
sounds like
Very
that.
good. It's very, very helpful for all of us as, you know.
Yeah,
Right.
it sounds like, you know, this is a
More
process,
practical also.
more, that will take more than 10 minutes.
Yes,
That's correct.
yes.
And
It is
that's
more-
what I
more
really
involved.
want,
Yeah,
yeah,
more
more
involved.
involved in
It
that.
also goes beyond into the community.
Exactly.
We're going to be taking it to the
So I think
community also.
it should
Let
be
me
like
ask you
a
a question. How many of you have advanced healthcare directives in place?
But no conversation
But you
with
know, you
family.
can
Right,
always.
but hardly any conversation.
Yeah, no
That's-
conversation. That's
So
the
that's the
important thing-
process we need to go
Right,
through.
what you're saying is that, what you're saying is right, the conversation, you can always change them, is the thought that goes into it,
Right.
and that you can always modify them. So
Yeah.
it's a
And also the
process that you-
conversation, not just the spouses, but also the children.
Exactly,
It's a-
exactly.
it's a different-
Okay.
And, you know, stick to advanced directives on the refrigerator. So, you know, it is easy, putting it in your locker is not the answer because nobody can get to them.
That's correct.
In your wallet, carry a little card saying, I have my advanced healthcare directive. This is the name of my agent. That's his phone number. This is my alternate agent. That is his phone number and
See,
email.
there's a lot more
So
detail than 10 minutes filling
Yeah.
out.
Yes, yes, it will be a
Yeah.
separate session.
We can do a 4-hour session.
Yeah, excellent. Let's
Yeah.
take that up.
I was asked to visit the family because the mother is 85 years old and she has a lot of chronic illness and she's almost incapacitated. And the son is taking care of her. And he says, I don't know how to talk to all these
Right.
issues with my mother.
Yeah.
So I did a home visit, sat with her and tried to explain things to her. And that's when the one we can go into detail as to
Yeah.
how difficult it
Exactly.
is
There's such
to
a-
raise this topic.
Yeah,
No,
Family
no, no, no.
situation.
Practice.
Because there's a lot of denial on both sides.
Yeah.
The mother doesn't want to discuss things in front of her son. And the son has her own agenda because he wants to know exactly what to do.
Right.
And he has two sisters, and of course the three siblings don't agree on what treatment the mother
There's a
should
lot of cultural
Yeah,
differences.
culture.
get.
And
Yeah.
oftentimes we see that the patient doesn't want to talk in front of the kids don't want to talk in front of the parent, and both know what's happening.
Yeah.
Right,
There's
right,
this-
behind the wall.
So I sat there with them for about 45 minutes, trying to, reach some kind of an understanding about her health issues and her prognosis as a physician and what she should do and what she should write in her advanced care directives. So I'm going to be doing that kind of field work now that I'm retired and looking at various scenarios.
And something I want to bring up, it is about old age certainly, but we often have kids at 18 going off to college. The times the court cases that you've heard of in life support, sometimes with very young people who are in accidents.
Well, I had
Yeah.
19-year-old.
So it is
And
exactly.
19-year-old young kids had
So
a
it's-
road accident.
Yes, a road accident. So it's a good idea. Maybe start with us, but just keep an open mind. It is truly for anyone and everyone over 18.
Even born, right?
No, but parents have some say. I mean.
There is one
A minor-
fundamental problem with all this. I mean, it is fine. We can all tell everybody we should prepare some form or directive or
That's what
something.
they're talking.
There are
But the
regular
problem is that the people don't want to admit to themselves that they are, in a sense, mortal. I'm putting it very crudely. But that's the real problem. It's not that they don't know. They know it. We all talk about it, we see it in writing, but that's not the problem.
So I have
It is the
a-
refusal to admit that,
Yeah. See, that problem, Veggie, is always gonna be there.
Yeah.
So let's work with the
Exactly,
one who
it
are
is always the other person.
Let's deal with the reality and the law.
Right.
Yeah.
So that-
And
So I have a different question
Yes.
to the both doctors. They gave a different perspective about prescribing the medications. You said you are not very comfortable in prescribing the medication. Now let me complete that. Like, I know you're doctors, you will obviously prescribe medication, but you mentioned that you are very good. I mean, I think your tendency is to okay, these are available, you should use it. I have a practical experience. Okay, one patient I used to visit have a severe form of arthritis. Okay, they prescribed some medication which has severe side effects.
Side effects.
Now, where is the comfort coming? Either way, I know that you doctors take them. You are not researchers. Already you have the information. You based on the research, based on the samples you prescribe, but those are not going to effectively work for everyone. Again, the samples are done on a particular race and age group, and now
whatever the medical industry is doing, like, because of their money or whatever it is, like, it come to you, you simply prescribe those things. Maybe some doctors have the experience of seeing as their own patients. Based on that, you might change your prescriptions. But there is no relief either way, like, either prescribing or not prescribing. There is the ultimate goal is to have some kind of relief, okay, for the patient.
That's right.
Okay, but there is nothing is there. Why doctors are not including alternative medications? Because either preventive or looking into some other thing rather than I'm coming to the work. Okay, this is. I was really upset with this doctor because he prescribed this medication. When I asked the questions, okay, this is having side effects. Oh, this is what is going to work. And I went back and searched on the Google and.
So what is your question? Why
the doctors are not looking into some other alternatives?
I'll say, and then you can. So the way we
because they will be
approach
trained
it,
to
the
think
first
that
approach
they
we
are
take as physicians is to do no harm.
No.
Yeah.
Right?
Yeah.
So we would typically not write for medication unless it's needed. So that's the first thing. So I will try, if somebody's.
It's only for managing. Okay.
All they do is to suppress the symptoms.
Let me complete. Okay. So as you prescribe the potency, okay, gradually the patient gets the resistance for that. You will end up in increasing the potency. But there are cases where you can take some other way of dealing the patient, where in my mom's case, actually, the doctor is ended up in reducing the potency because she is doing something else. But I have seen the cases where people are not proactively interacting with the doctors because as a doctor, you know what I tell, okay, other than referring the test. But basically, more what I tell, you can diagnose properly, correct? So there are a lot of cases in general, like, doctor is prescribing something, it's working, again, the potency has to be increased. There is no end for that.
So the problem with hypertension, since we brought that up, is it's a progressive illness. It is unfortunately going to get worse over time. And so if you got started on lisinopril 10 milligrams, for example, very likely 10 years later or 7 years later, usually, but maybe even 5, you need a higher dose. One thing I'll say, actually I'll say 2 more things and then I'll turn it over to you. One thing is, we all review data. So, like you said, that's one thing, one reason I like practicing in this country, because a lot of it is done based on evidence. The other thing is, I think I finished medical school, actually, I finished residency in '92. I've got my own data now. I have seen how treating hypertension really saves lives. Stroke risk, kidney disease, heart attacks. And so I strongly believe that. So that's one thing to say, that treatment of hypertension is important. But the other thing I'll say is, you're right. I grew up in India. I should have more knowledge about, say, Ayurvedic medicine, but I don't. I went to medical school in India and then I trained at UMass. There was nowhere that I learned, homeopathy or Ayurvedic, even though the Ayurvedic college was down the street from my medical school in India. They should have maybe had us take some classes there. So I am the first to admit that we have very little alternative medicine knowledge. I've learned a little bit over the years, but in no way is that complete.
But even if you had the knowledge, can you get Ayurvedic medicine here? Like, can the doctor prescribe it?
No.
So I can
So
speak
that's the
to that.
problem, right?
If you need Ayurvedic medicine, obviously you will go to an Ayurvedic doctor,
That's
or
right.
a specialist.
Right.
So I'm giving my personal experience. I have osteoporosis, and the medication for osteoporosis are giving me side effects, and I was taken off it. So this last 2 months I spent in India looking at alternative medicines. So I went to this Ayurvedic hospital and did whatever they asked me to do. And I guess 2 months is too short a time, but I found zero benefit. I spent a lot of money because they knew I was coming from the United States. This woman had a lot of dollars she could use here. So went through whatever they recommended, the medications that I had to take morning and evening. So the question, your question is, person has an arthritis, one type of medication didn't work. The physician who specializes in that field will give an alternative to that. But the question is going to be, how is that person's body healing or not healing? So some diseases, we have no cure.
for rheumatoid arthritis. There's no cure as such. There are newer and newer medications coming out. So then a general practitioner trying to handle it, they'll send it to a specialist. But always there's going to be some limitation.
And talking about, Ayurveda, also know that, what you call natural Ayurveda also have side effects. Ayurvedic medicines are known to carry heavy metals, lead, mercury. So everything is not benign. The most potent things like digitalis, the medication for heart failure, comes from a herb. So know that there's also a mixture how your natural medication or Ayurvedic medicine would interact with some other medication that you're taking.
Sometimes
In response to your question, I think it's really important to also know that I think a lot of us want to reach out to alternate, whether it's homeopathy or others or just self-discipline. So there has been a movement, and I think everybody here is familiar with, which is the chronic disease self-management. If you Google that, chronic disease self-management, there's been a great deal of work that's happening internationally. It started at Stanford, but it's kind of gone everywhere. And what it is that it's not that discounting the medications, because for certain diseases, as we get older, sometimes as it was just said, that it is progressive. But chronic disease self-management is kind of more of a self-discipline whereby you're using other methodologies to manage it. So, for example, people who are hypertensive, more walking, actively looking. I mean, I come from a family of, so many high hypertensive, but they will refuse to put less salt, or just exercise, or some of those alternate therapies that will work. So chronic disease self-management is happening. If you Google it, there are lots of support programs going on for people actively trying. But coming back to my comment about extra medications, I think what I was trying to say is for older adults, the discipline of geriatrics does not exist outside some countries. And I struggle with it. You have so many uncles and aunts that they were put on a medication 10 years ago, some medication 7 years ago, and slowly their bodies have changed. But those medications have not been assessed. That's what I meant by saying somebody to look at the big picture, like maybe an internal medicine doctor like her, who is very intuitive, who looks and says, okay, she doesn't need this, and this particular medication can be interactive. And the last thing I want to say is that having been in an academic teaching center, we find that people will, so neurology will give you a medication. That may impact with endocrinology. That may impact with cardiology. So looking at the big picture is what I express.
And I see a lot of that in my specialty, every medication interacting.
That's right.
But speaking to your point that alternative modalities are getting included, we don't have any research behind it, so that's what is lacking. And but Kaiser has a database that they've come up with an initiative called integrative oncology, where they're incorporating acupuncture, meditation, mindfulness, even herbs. And we have consultations in our clinic where, if you were interested, there's a practitioner who's trained in alternative medicine actually sees you and prescribes you medications. So there's a movement that's going on.
Yeah. In fact, I wanted to make 3 points, and I think you just made one of them. More and more, at least the major hospitals and centers in this country are coming up with looking at what they call complementary or alternative medicine. You'll find departments called CAM.
Yeah.
They also call them integrative medicines, where they're taking allopathic and integrating them with mindfulness, yoga, and so on and so forth. So you can look for those. The second point I want to make is that you say, why didn't the doctor do this? Why didn't the doctor do that? More and more, we as educated, informed patients and caregivers and family members need to be more proactive and advocate for ourselves. I think advocating for yourself and your family is an important skill that all of us need to learn. Doctors try their best, but there's no point in saying the doctor did this, doctor didn't do that. You need to have an informed discussion with the doctors. And the doctors, if you are, rather than pointing fingers, if you're willing to have a discussion and ask for reasons, they're going to be coming back and talking to you, right?
I agree, because consumers drive the care. So a lot of more and more patients are coming in, they're already taking herbs and supplements, they're just not telling us. So that's what initiated the movement in Kaiser, that we need to know what you're taking so it's not interacting with what already you're on, or we can guide you appropriately. So that's how the care is shifting. So I think we will reach a blend where it'll be a blend of all of these modalities, not because Western medicine doesn't fix anything. It just puts Band-Aid. That's what it does, yeah.
And it's good to have one doctor like your primary care physician, your internal medicинist, as a person who knows your history and who can provide holistic care. If you go from one specialist to the other specialist to the other specialist, one does not have an understanding of what the other knows or doesn't know.
Yeah.
So the interaction is
Interactions are huge.
Primary care is the key, your main person. Yes, ma'am, you had a question.
So I just wanted to say two things. Having gone through my mother-in-law's latest cancer, death and stuff, sometimes what happens is people hear, oh, there's a cure in Ayurveda for this. There is no known cure for cancer in Ayurveda, period. I don't care what anybody tells me. There is no known cure in Ayurveda. But
There is
somehow
no
there is
known
this.
cure in anything. I mean, it's a matter of percentages rather than cure.
No.
What is cure for cancer?
Let her finish it.
So, but it's wishful thinking on somebody's part. My mother-in-law's cancer was diagnosed when she was already at stage 2. Her options were, she could have had the lumpectomy and a couple of lymph nodes removed, and she could have, lived. But she didn't want to go through the surgery. She said that some Ayurvedic people told her it can be cured. So she took that medicine for 8 months, and then it was stage 3 and way beyond that. So I think what Mukund says is right. We have to be educated about whether some things are true or not.
Yes.
And then comes a point of time where there is no point of turning back. And in that stage of no matter what you do, nothing is going to work for you. So,
I just want to share my father's experience on that. My father passed away about, I would say, 12 years ago, and he was in India, and he had been, taking medication from one doctor to the other, and it was pretty, it wasn't a whole lot of, medical care available in the town. So, you were traveling from Delhi, Chandigarh, Jalandhar, you name it, from one doctor to the other, trying to find some care. And as Mukundji said, unless you're observing carefully and you're being an advocate for yourself or for your family member, I hate to say it, some doctors don't know what they're doing.
Correct.
And I have tons of medical practitioners, doctors, cardiologists, radiologists, you name it, in my core family, in my nuclear family. We have a dozen doctors, So I tell them to their face, sometimes doctors don't have all the answers. You have to live with that. And then what happened in this case was my father became very lethargic. After one medication for like 3 times visit, became more and more and more lethargic. And my mother, who was the primary caregiver, she decided she's going to discontinue that medication. She didn't ask anybody. She said, no, it's not working. I see him. He's getting a lot more lethargic. It's not working. I'm going to discontinue. And that worked.
Yeah. So, Kamleshi, I'll just add my experience here as a CRF patient caregiver, primary one. And I totally agree to what Mangalaji said. Very cautiously, I would say, certain things. Right? Some alternative medicine therapies may promise a lot of things. And I'm coming critically from the CRF point of view. I've tried 12 to 13 different possible options.
I'm not sure. What CRF?
Chronic renal failure, where your kidneys function is going to deteriorate over a period of time. So I totally agree with the doctors here on the forum saying, but just by reading WebMD online, and I've been reading a National Library of Medicine data since '93 when it was introduced, the internet connectivity happened in India, that time onwards, right? I can become knowledgeable about the subject, but I would never be able to equate the experience and formal classroom learning which a doctor goes through, right? The grind they go through. And Dr. Sajeev touched there on one very critical point there. Doctors in their education learn the protocols, but in their practice, they bring in their experience of looking at the patients and then evolving their practice, right? So it is it is a very involved area.
Absolutely.
What would help by your reading WebMD and other sources is you'll be able to ask intelligent questions to the doctors. And I've seen in my experience of dealing with nephrologists across the country in India and running the 2 dialysis centers myself thereafter as business, is doctors pay more attention to caregivers who ask intelligent questions.
No question.
That also demonstrates at the level of detail you are interested in your patient, right? It's very easy to get emotional about it, but it has to be a very balanced view that you have to take at times, right? But in my view, certain modalities cannot really treat a disease after it has taken a turn, right? And allopathy in some areas has options, but medicine is not perfect, right? We are still evolving.
Yeah.
Down the line, 5 years, we'll have designer genes and stem therapy, and a lot of things would evolve there. But we're not there yet, right? We would live up to 140 years in near future, but we are still far away from that. Art and science both.
Absolutely.
Single cases do not justify the treatment modalities which are offered across the board. So we have to be very cautious. No self-medication. And in fact, Siddhava talked about a lot of treatment plans and investigations and all. End of the day, as counselors, we have to leave it to the doctor to administer and prescribe. We are not that. We are going to become intelligent about what is going to happen in certain cases and all, but we are not becoming doctors here, right?
Yes. Oh, absolutely.
So there's I can do a lot of jargon, medical jargon, because I'm collecting that information over the last 25 years. But I would still stay away from being a nephrologist myself, right?
So there's a comment from Eknath online, so I just want to give Eknath.
Namaste. So hope you can hear me.
Yes.
Just a comment in terms of critically ill conditions and when in the case of patients as such. So if the alternate medicine, they strongly believe in it, and they if it gives them a chance to a better last few days, I think that option should be considered, even though there is no research data that says that it works one way or the other. Maybe it will have placebo effect and
I just want to talk 2 minutes.
I just want to say we are here today as chaplains or community health Hindu community workers. In our conversations, trained as a chaplain, I did not discuss what medical issues were there, so which medicine works, which doesn't work.
That's right.
And I would strongly recommend we all read the book by Gawande, We Are Mortal.
Atul Gawande?
His parents, who father who died was a physician, he himself was a physician, he's written one or two
Great
books
writer.
after that. So, we are going to address, in fact, my talk is going to address the issue of what is beyond the body. So all that you heard here, I stand for the body. But being Hindu community initiative and working at that level is going to be a different thing.
I think there's also a question of faith. And faith, if somebody believes in Ayurveda, you're not going to shake that.
So I think this is a good segue. We've got experts here who've given us talks about various issues from aging to good health, palliative care, and so on and so forth. All of us as people who are going to go out and go into the community to serve people, if you can think about their talks and ask them questions that would be related to how you can go out and help serve the community, I think it would be a good time to pick that.
And to respond to Mr. Eknath's question, via the internet, absolutely, I think there is no harm in trying alternative medicine, but after some reading, education, consultation with with the Ayurvedic specialist, and then mention to your primary care physician that these are the medications, Ayurvedic medications
that I'm taking.
To avoid interaction.
Yeah.
But then I would say it's a judgment on when you take them. For example, cancer is your judgment. I would say you can do both things together. I would say if you're having a horrible asthma attack and you can't breathe, you're not getting oxygen. That's not the time to take your Ayurvedic or homeopathic.
That's right.
So that's the time to call 911 or go to the ER. But for chronic management of asthma, to decrease the frequency of asthma attacks,
Yes.
certainly, absolutely go ahead and use other measures. So that's
I have seen patients do well.
I'm reading on Abdul Gawar's book. I read it. In that most of the time people hesitate to make any decision purely because of lack of information.
Yes. Yes.
That is pointed out in Dr. Abdul Gawar's book. The lady, she was one of the things, she kept on saying, I want this, I want that. And finally he pinned her down and explained her all these things.
Yes.
Then she realized, oh my God, why nobody told me about this?
Yes.
You're
100% right.
Yes, the information. It's, if they don't have the information, they are fearful of things. If I get into this, what will be the consequence? If I get into it, what will happen? And then, by getting into all the things, especially the advanced directive, spare the world for the whole body, hospital, family, and relatives, and everything.
So this is a very, very important point that you bring in. I'd like to bring in a study that the university was carried out at the University of Calgary in March of 2017. A paper was published in a medical journal. The South Asian population is the largest minority ethnic community in Canada. And so they noticed that the Indian population was not filling out their advanced directives. And there's a big study at the University of Calgary as to why that was so. And of course, all the cultural thing that we have spoken about, if we talk about something bad will happen. But all of those things came out. But one thing that came out was that the Indian community is very receptive to information if given. And then they saying we want information, and from then we can take it from there. So that is what we can do here and be the yes. And so this is we know it intuitively, but this was the actual study the University of Calgary did, and I'm happy to share that study with you if you like. I have a copy with me in my lab.
Yes. You see, whatever all the 5 doctors spoke is practically applicable to me, because my wife is third-time cancer survivor. Since last 15 years, we are treating. And how to treat or how to take care of the patient is, listen to, you see, doctor in India, Dr. Chandrasekhar, who treated for her breast cancer in my senior, I asked him, will you give guarantee? She is in stage 4. He said, I cannot give guarantee. So then I spoke to him and he treated very well. He got her septum from California to there. What I want to tell, now she is undergoing ovarian recurrence cancer at Valley. Oxyl is being used now. So what is most important for all of us learning from them is what they are teaching, let us understand. Let's not get into the other details. And I am, as a person who is attending to her since last 15 years, I am very happy with whatever they spoke, and only 80% I understand.
That's a very
because I am practically understanding this, whatever
you've been living through.
In my seeing day to day life. So it's very difficult. It's not, you see, practical. I am sleeping with my wife. I am sitting by her side. So
you have lived through.
Yeah. 50 years, 45 years, 50 years from her.
I just want to read a quotation to you that I came across this morning. No. For a graceful exit, the person writes, I do not want to relinquish control over how I will die. However, I do not want to be treated to death.
I'm sorry, could you repeat that second half?
I do not want to relinquish control over how I will die. However, I do not want to be treated to death. So what you're looking for is like multiple treatments, this and you go on and on. So, once you have control over decision making of the thing, but not yet.
So looking at it from just
you mentioned your wife has fought through a lot, and she's essentially overall healthy from what you mentioned. I'm sure
she will be equally like all the women sitting in this room. I mean, you will never find her.
He's also a great caregiver.
Absolutely.
Yeah.
Absolutely.
I love her. Let me be honest with you.
That's the main thing. Keeps everyone right.
You see,
I think she is very careful. I mean, her health is 200% perfect. She will live for 100 years. So what is most important is understand what word by word what they are talking.
And utilize whatever you can get
Yes.
from this, you know. That would
I
be
think
in our Hindu tradition, what I find, just as a kind of a lay person, I'm just observing it, the respectability for death is lacking. That is fundamentally a problem in my mind. And I think one of the things we can do is appreciate the whole mortality concept. Who are we, our mortality, and put death on a very highly respected level. Because we're all born, we are going to go. And yet, the whole life is spent dancing around marriages and all that stuff. And when it comes to death, the temples don't worry, but they want to touch it. The priests are very difficult to find. I've seen that. I think the respectability of death, the one message for us as counselors, our mindset, put death in a very highly respectable plane and deal with it. The directives, the care, the palliative care, normalize it. That would be an amazing accomplishment for our community.
And you know, combining
look at death as a part of life.
That is part of
It's
life.
a process of life.
I think that to me is
So especially here when you're combining it with Vedanta, Gita, and then
Exactly.
you go out
It
with
all
that
flows
one and
together.
it flows together. It really flows. Without that, by itself, it doesn't.
Exactly.
You have to, that gets us.
And talk about it that
Talk about
fashion.
it. That's right.
And
But
the
it's
only
okay.
way you can basically relate death as not only a stop, but a beginning of something else.
That's right.
Yeah, spirituality has much coming.
So to that, I would add that, it's a fact that we all know whether we want to talk about it or not, we're all going to die one day, right? So what you want to try and do, and the message that you want to try and convey, at least this is what I'm trying to do, is you don't want to focus on death. You want to focus on maximizing the quality of your life that you have right now, and maximizing the quality of life of all those around you. Right? So if you approach that from the point of view is at every step that I make, what is the decision that I can make that's best for the overall quality of life? Getting to death, approaching death, realizing death is going to be something that comes into place as a matter of course.
I will end by saying that what you just said, Kailash, is because, I have intersected with you on some very pivotal times of our lives, that I think that the shift has come in our lives where we are looking at prolonged life in a different way, in a very optimistic way, that there is control in treatment, there is also acceptance of the afterlife. And I think this is happening because I'm seeing more and more of these discussions. I mean, things like geriatrics and palliative care don't exist in India, but there are conversations happening. So it's with the help of people like you, who are thought leaders, who are combining the spirituality and the knowledge. That's how we will continue. I mean, if you can impact 10 more people, imagine what progress we have made.
And there's a huge need in our community.
Yeah.
By the way, that's part of it.
Yes.
Part of this institution.
And this is something that has happened actually.
Go ahead.
I want to share something because I'm a cancer survivor myself. Gone to third stage and gotten the treatment. And because for me, it was a lot more easier to compare to any other people because I worked in the hospital. I have seen so many things. And I had a lot of support from my doctors because I worked with them and things like that. And then I walk that way and I know, and even today I'm continuing to take the cancer medication. So that's how it is. But by knowing the support system, I don't have any family members here except my children. But it doesn't matter to me at all because I'm not having a family. Because when I came here, there wasn't anybody. Okay, then I think, how did I survive with all these things? By co-workers and the friends and the family and things like that. And also at the temple, the priest was very, very supportive. And the doctors were very supportive. My co-workers were supportive. And they were all day after day, they kept taking me for the treatment and then being with me, calling and doing all the things. That's how my journey went on. It still continues that way. And then so it's accepting and also knowing what it is happening to you. And that's the important thing, is the information.
That's right. Yeah, very, yeah.
Just wanted to emphasize the fact that you have chapters. And the basic question always, Vedanta is, who am I? Who's the I that's going to die? And that's the basic fundamental truth. So you got to break it to make people realize that we come from a tradition of Vedanta. And now with the leading advances in science, we think we can, get this body made. The lifespan is increasing. My mother is 98. So, and she came from Pakistan and very poor diet and everything. It's amazing that she did. The lifespan is going on increasing, but there's still going to be more. The body is going to be more. So the message you give to the person is, you are not going to die. The body is going to die.
And there's a very good book by Anita Murjani, Dying to Be Me. She talks about her, near-death experience. She just talks about that the body is what you shed. Your soul is this fabric of the same being. So,
you change your clothes. You wear from one set of clothes to another set of clothes.
Yeah.
And that's what basic philosophy. So why are we getting away so lost in the science and this thing?
One of the things we're all having here, if you haven't realized it, is we're having the conversation. Right.
Yeah.
Right? So I encourage all of you to continue to have this conversation with your family and your friends and get this out in the open and start to understand each other.
I'm here to help you all. If you all want to stay, whoever wants to stay, I've blocked advanced healthcare directives, walk you through how it should be filled. If any of you are interested, you can stay and do the workshop on the workshop. Have a conversation. Have a separate workshop.
You can also go to Sukham.org. You can also go to Sukham's website and all the details there.
Thank you, sir. So I just want to thank, I want to thank all the doctors. Thank you very much for coming.
Thank you for having us. Thank you. Yeah.
Opened our eyes and we will call you back again if we have a lot of questions. Thank you very much.
Many of us are going to leave right away. Dr. Jyoti will still be here for some time. If you have questions, do connect with her.
I have just one more announcement, and we'll just go closing prayers and we're good to go. One more announcement is next weekend is great because of Thanksgiving. So please enjoy Thanksgiving, but take the time to go back in and do your homework. We're on to you. We're seeing who's doing your homework and who's not. So please finish those. If you have questions, send those out back to us. And if you have any questions or comments or feedback, please give us those. Yeah. So I have a question on timings. It's getting darker, and the way the air conditioning here is, we don't have heatings. Can we do the class earlier, say 12 to 4? Is that okay for everyone?
I think that's a good idea.
No, they can't. You can't, right? No. Yes? No?
Yeah, yes. No, I don't know.
But you have another class to come from, right? Okay. So we'll start to deal with it. Okay, so we'll just figure this one out. All right, closing prayers. Please sit down. Sit comfortably. Sit in any comfortable posture. It's all right, however you sit. Please sit with your back straight. Close your eyes. Relax the expression on your face. Relax your shoulders. Relax your belly. We're going to chant Sarve Bhavantu Sukhina after chanting Om 3 times. Please bring your palms together at the heart center. Bring your attention to your heart. Exhale completely. Take a deep breath. Inhale. Inhale and hold. Chant.
Sarve bhavantu sukhina, sarve santu nirabhaya, sarve bhadrani pashyantu, ma kaschit dukkhabhag bhavet. Om Shanti Shanti Shanti.
You rub your palms together to generate continuous and gently cup your eyeballs after that seat. And then massaging. Pull your palms back and open your eyes. Thank you. Okay. Thank you very much.
Thank you, Guru sir.
Thank you for people online.